Now, all right, so we're going to start today talking about wound care some more. So it's February 1st. Amazing. We're in February, guys. Christmas is right around the corner. We're going to talk about specific things with wound care today that we didn't really cover last time. So we're going to cover the ABI, the ankle brachial index. We're going to cover, and the reason we're going to cover that first is because when we get down into pressure injuries, arterial wounds, venous wounds, diabetic wounds, burns, stuff like that, we go off of the ABI. And so if I don't talk about that first and I say, well, we do the ABI test, everyone will be like, well, what's the ABI test? So we're going to cover that first. Then we're going to cover pressure injuries, arterial wounds, venous wounds, diabetic wounds, burns, which is usually the worst portion of this lecture, but for me, lymphedema is the worst portion. And then some amputations. We're going to see if we can cut it out. So the ABI is one of the tests we use quite frequently when dealing with different pressure wounds and pressure injuries and ulcers and stuff like that. The ABI is the systolic pressure at the ankle divided by the systolic pressure at the arm. So that means you have to be able to take blood pressure of the leg. What arteries do you think you're going to be measuring or listening to if you're taking blood pressure? Well, that's going to be way up. Okay, the pedals, right? Specifically dorsalis pedal dorsalis. I can never say that one. And then also posterior tibial. I mean, you're welcome to listen to femoral, but you're not going to cut that off. That'd be a really big cuff to get around my thigh. So you're going to take blood pressure at the leg, and then you're going to take blood pressure at the arm. Why do you think that might be different? What's different between the arms and the legs? Closer to the heart, good, right? The arms are definitely closer to the heart. We'll just also think size-wise, right? Especially when you got somebody like me who has tree trunk legs. My legs are definitely different size than my arms. I don't have, I ain't swole is what I'm saying. So we're going to check to see if there's a difference, right? There's been shown that a specific and sensitive metric is used here to help us diagnose PAD, or peripheral artery disease, meaning the arteries are starting to fail. What's interesting is the ABI actually has been shown to predict mortality and adverse cardiovascular events independent of traditional CV risk factors. So literally, if the patient has really not a ton of risk factors for cardiovascular events, like maybe they don't have high cholesterol, they don't have high blood pressure, they don't have anything that's normally an indicator that, hey, this person's probably going to suffer a heart attack at some point. If we do the ABI and we notice the ABI is off, it still shows us that there's a good chance this patient's actually going to have some form of a cardiovascular problem in the future. Maybe a stroke, right? Major cardiovascular societies advise measuring ABI in every smoker over 50, every diabetic over 50, and all patients over 70. So if you've got Mima or Pop that are over 70, you can always practice on them and see what their ABI looks like, right? So you're going to measure the systolic blood pressure from both brachial arteries. So you're going to measure both arms and then both dorsalis pedis and posterior I can speak today, tibial arteries. Now the key thing here, and this is a mistake that a lot of people make, they'll throw the patient up on the table and tell them to lie down, and then they'll just start taking the blood pressures. They have to be at rest for 10 minutes before you take the blood pressure. So you have to put them up there. If you're going to do this at the beginning of a physical therapy session, good idea to go get them a little bit early and then just have them lay down, maybe give them a nice hot pack to lay on their back or something to say, just relax for 10 minutes. Systolic pressures can be measured with either the Doppler or a handheld pressure cuff like we normally use, right? It's usually recommended to begin with the right arm, the right leg, then left arm, or left leg and then left arm, just so you kind of go in a circle. And the blood pressure can drift during the exam. That's why we take both arm blood pressures. So we're going to calculate an ABI for each leg because each leg could be different. So the one thing we'll do is we'll take a pressure of both legs, but both legs will be divided by the highest of the brachial artery pressures. So there should be less than a 10 millimeter difference between normal people, and it should be recorded 2 decimal places. This kind of shows us what we're looking at here, right? So we're going to take the highest blood pressure on the right foot and then the highest divided by the highest blood pressure on both arms. If when we average that out, we're either at a 1 to a 1.4 in that division, it's normal, meaning if the legs are a little bit higher than the arms, that's pretty normal because our legs are bigger. Varicose veins wouldn't affect necessarily, good question, Adrian. So Adrian asked if varicose veins would cause an inaccurate blood pressure reading. Not usually. Now, if somebody's got peripheral artery disease, for sure it would cause inaccurate readings. So if somebody's got, really bad, arterial atherosclerosis, definitely could cause some problems. That's why we're taking this. But we're not actually measuring the pressure of the veins. Now, it could be uncomfortable for people with varicose veins, right? Because those veins are kind of not functioning right. So you put that pressure cuff on, it may be a little uncomfortable for them, but it's not going to affect the ratings. And if you look, when we get down to the low levels that are 0.5 or lower, or 0.8 or lower even, when you think about that, what that's saying is the arms themselves have a higher blood pressure than the legs in order for that to be that way. And that should tell us that, man, if the arms have a higher blood pressure than the legs, that leg is not getting blood, right? So what do you think? What do you think if a patient did have this, where they have a really low ABI, what do you think they'd complain about with their legs? What would be some symptoms they might complain about? If my blood pressure was really low in my legs, maybe some numbness, okay, right? At the extreme end, yeah, the legs are always cold, good, right? My feet are always freezing. How else do you think the legs would feel? Yeah. Heaviness is usually more towards the veins. Could be tingly, good, right? Because you're starting to starve some of the tissue for oxygen. And weak, weak. And often they'll say they just feel sore and achy. Yeah, right? Think about it. So all those big muscles, especially your calf muscles right now, are starving, right? They're not getting enough blood pressure or enough blood in them. So they're going to feel kind of achy and tingly, and they're just not going to feel right. And they're going to say, oh my God, they're cold. That helps us understand this. That'll come into play when we talk about the arterial wounds specifically. I did put a Stanford Medical link here for you guys on how to perform if you need to watch a video of it, but I think you get the idea of taking blood pressure in both. So the first thing we're going to talk about is pressure injuries, right? These used to be called a couple things, right? We used to call them decube ulcers. We used to call them pressure ulcers. We don't call them ulcers anymore. Why? Does anyone know why we don't call them ulcers anymore? Why do we call them pressure injuries now? I think I might have mentioned this before. Maybe not. Or maybe people just aren't awake yet. Yes, right. Pressure injuries on our part. That's exactly right, right? Ulceration means we really didn't have much of a chance to prevent it. Like when we talk about arterial ulcers in the future here, in a little bit here, those are caused because of the patient's own arterial system, right? It's not much. I mean, we can help the patient. We can teach them methods. We can help them, get a little bit better. But in reality, we can't stop that. Pressure injuries we can prevent, right? With the appropriate care and preventive strategies, the majority of pressure injuries are both preventable and treatable. So whether they come in with one that we didn't cause, we can treat it. Or more importantly, we can prevent it, right? Pressure injuries occur as a result of intense or prolonged pressure, frequently pressure in combination with shear forces. So that shear force really hurts when we kind of drag them across stuff. Soft tissue has a certain pressure tolerance and integrity. Once that exceeded, injuries occur. Everything can kind of affect those pressure tolerances though, right? We can be affected by microclimate. In our area, it's pretty common to get pressure injuries because of the dryness, right? It's definitely not like the East Coast where it's moist. But ironically, even on the East Coast, they have a different effect. Because it's so humid and moist, they can end up with macerated skin, which can cause pressure injuries. Nutrition's important. Perfusion, meaning are they getting enough blood out there? Hydration. Do they have any comorbidities, right? Do they have any underlying tissue condition? Did they previously injure the skin? Like for me with my scars on my neck, if for whatever reason I would end up laying on my neck for long periods of time, those scars that I have on my neck are at higher risk to get pressure injuries because the skin is not as patent as the rest of the skin. Are there any medications you can think of that might cause patients to be more susceptible to pressure injuries? What's our favorite one that's come up a couple times now in wound care? Yeah, anticoags, right? Yeah. You got to think about it. Those anticoags make it really easy to bleed. You know, and maybe they spend too much time on it and they start bleeding internally. Well, that bleeding internally can kill some tissue and they end up with a pressure injury. So here's the interesting, I saw this and I was kind of set aback by it. 10 to 15% of the population suffers from chronic pressure injuries. Think about that. It's like 32 million Americans suffer from chronic pressure injuries. Like, to me, that blows my mind. What can cause them? Spinal cord injuries. If I've got a spinal cord injury, I don't move as much as normal people. CVAs and TIAs can lead to people getting them. Long-term care bedridden patients, so patients that maybe are in comas or something to that effect. DMD, Duchenne's muscular dystrophy, or actually most of the muscular dystrophies, even Becker's. As the children get older and older and they start becoming less and less ambulatory, it's real common for them to start developing pressure injuries, or maybe even we'll talk about with orthotics or splints where patients don't wear them properly. ALS, really common for them to get pressure injuries, especially later in the care. I was just reading a story about how the guy from the New Orleans Saints, Steve Gleason, there was a write-up about how he had developed a pressure injury on his right ischial tuberosity and how they were treating it. And he wanted to bring attention to the fact that, you know, patients need to move more frequently if they're ALS patients. Children and adults who use assisted devices long-term, or more importantly, improperly, right? Those are the patients that are using axillary crutches and kind of hanging on them, right? Or you'll see them with forearm crutches, and the forearm crutches are going up and over the olecranon, right? And then every time they push up through it, they're rubbing that olecranon. That can lead to a pressure injury. This is another big one. Adults or children who use orthotics like splints or braces that wear them long-term or improperly, right? You have somebody that wears a brace on their hand long-term, and, you know, patients often think a lot of times the tighter I put my brace on, the better it is for me. Anyone ever see a patient that come in with like that and maybe either their toes are white or their fingertips are white? Yeah, Kaylee's like, yep. Right? They're like, if I've got a brace on, it's got to be super tight. And then they'll, why are my fingers numb? Right? The braces have a certain tolerance, but even those, when we design those braces or splints, that's me, Jesse. Yeah, exactly. Right? If this corset's not tight enough that I can't breathe, it's not right. I see that a lot with back patients. They're like, so I'm supposed to have this so tight that I can't breathe, right? Yeah, that's exactly right. But think about it, like if I've got a long-term forearm splint or something like that, maybe because I've got wrist drop and they're positioning me so that I'm in kind of more wrist neutral to function. That whole wrist, everywhere that it contacts bony prominences, right? Your styloid processes up here in the palm, anywhere down on the forearm that we're hitting those bony prominences, those are areas of what are called pressure sensitive areas. We're going to talk more about that in prosthetics, but anywhere where those big bony prominences are kind of banging on that orthotic, right? That's going to be an area that's going to lead to breakdown. So what might we want to do in those areas? What do you think? More padding, right? Or at least appropriate level of padding, right? We don't want just hard plastic there. We also want to make sure they fit, right? The splint that's maybe from my right wrist is not going to fit Jesse's right wrist. Her wrist is a lot. So actually, my wrists are pretty tiny. I have baby wrists. So maybe they might fit her. But, you know, something that's designed for my knee is not going to fit Jesse for sure, right? She's a lot smaller than me. Or worse, if they take, you know, they had Jesse using this knee immobilizer, and the PT's like, well, we'll just use that immobilizer, and tries to put the immobilizer on me that she was just using. That's definitely going to cause some problems with my leg, right? So we got to protect them. But patients, again, don't do that. What assistive device do we use, or protective device that we use, could we put on a patient that could cause a pressure injury if we're not careful with it? Yeah, the gait belt, right? If we're not careful with it, we could definitely cause them a pressure injury. So that's why it's usually a good idea, especially if you've got somebody that's older, to check them after you take the gait belt off. Make sure that they didn't cause any sores or anything like that. Tighter is always better, obviously, with the gait belt, but within reason. You don't want to crush the ribs and give them a pressure injury. And then amputees who do not perform appropriate residual limb care. This is a pretty big one. And we got to be careful with this, because if they've already had an amputation and then they get a pressure injury, what's that likely to have them happen again? Another amputation. Right? This is that patient that, you know, gets a mid-foot amputation and then doesn't take care of it and just bangs it off everything, gets some more pressure injuries on it, and then ends up having a whole foot amputation. Then doesn't take care of that and ends up with, you know, a below knee amputation, then ends up with above knee amputation, and eventually ends up with the hip being disarticulated because they just don't take care of their residual limb. And we'll cover that in when we get to amputations, but it is residual limb. What is the word we will not use for it? That we used to use pretty exclusively for amputees. Stump. We're not doing stump care. And I am as guilty as this as the next person, because that's been ingrained in me. We are taking care of their residual limb, not taking care of their stump. Stump just sounds kind of negative. So what can cause pressure injury? Any wound caused by pressure, shear, or both can cause it. The interesting thing is pressure injuries can develop in under 24 hours. Most commonly on bony prominences, but can occur anywhere. The pressure on the prominence is transferred to the underlying tissue, compressing the soft tissue between the surface skin and the bone. When that pressure exceeds the capillary blood flow, flow will be obstructed and local ischemia occurs, and the necrosis is quick to follow. But then where are they common? Here's the key thing for your boards and also for my test. If you're given a position as patient is placed in, you should be able to name multiple points of pressure using anatomical terms. So let's look at me. I am laying prone right now, so I'm going to lay down on my face. Give me 4 pressure sensitive areas of a patient laying prone. Okay, knees, got one. Good. Patella, good. We'll count knees and patella as 1. Cheeks, right? Depending on how I'm laying, definitely. Specifically, what part of the cheek? If I'm laying with my face turned to the side. Zygomatic arch, good, right? Ear, definitely. That's one I see frequently. Shoulder, right? We shoulder knew that. Specifically, what parts of the shoulder? Good, the AC joint, the acromion. What about right down the center of my body? Right here. Sternum, right? Yeah. Especially when you kind of get to that body of the sternum, the bigger kind of broad part that kind of arches up, definitely there. If you're getting a pressure injury in your xiphoid process, yeah, ASIS, good, right? So you should be able to do that if they're asking you, you know, and for the boards, what they'll typically say is something to the effect of, you have a patient lying in side lying, which of the following areas are pressure sensitive areas and could develop pressure injuries? And then it'll give you something like PSIS, nose, greater trochanter, or posterior aspect of the calf. And you have to know, oh, well, they're laying on their side, so it's going to be greater trochanter, right? So you have to be able to identify, based upon the patient's position, where those pressure sensitive areas are. So this is kind of looking at a couple of those areas, right? 95% of all pressure injuries occur on the sacrum, greater troch, ischial tube, posterior calc, and the lateral mal. What might cause pressure injuries on the malleoli? Even without laying down. Maybe somebody that's ambulatory. What could cause pressure injuries on the malleoli? Poor fitting what? Shoes. Yeah. Right? Specifically poor fitting shoes, or that person that really likes those really super tight boots. Right? I've seen a couple back in Pennsylvania when, the guys were wearing those, fancy cowboy boots. I got my crap kicking cowboy boots on. And for whatever reason, and I don't understand why people want the boots to be skinny. Maybe it makes their legs. New boot goofing. Yeah. I don't know if maybe it makes them feel better about their legs. I have no idea why. It just seems like every guy I've seen that wears those back in Pennsylvania have them way too tight. And then it's putting pressure on those calcanei, the genuine ostrich. Genuine ostrich boots, exactly. But sneakers can as well, right? Especially like, those mid-range, what did they, like when I was coming through, I think they were cross trainers. That's what they called them, right? The cross trainer shoes that are the difference between your normal low shoe and then your high top. But even your high tops, if they're not properly padded, could cause pressure injuries, right? So you have to be aware of that. If you're buying, if you're buying shoes, especially once you guys get older, you'll find that you may have to spend a little bit more on shoes for your feet not to hurt as much. With you all being younger, you pretty much can put shoes on and survive all day without your feet getting too sore. But I guarantee you, once you get to my age, you'll really appreciate the good shoe. Birkenstock. Yeah, it's amazing how much you start appreciating good shoes once you get older. I didn't think I was that much of a big deal. And then I got a good pair of shoes. I'm like, I like these. So shear can cause it, right? Remember, the skin itself doesn't move on its own. The musculoskeletal system moves the skin, right? Excessive moisture can cause maceration. And remember, maceration is where that skin kind of rolls up. Decrease impaired mobility, right? Anything where they stop moving as much. Malnutrition, dehydration can cause risk factor. Impaired sensation. The older we get, the less pliable our skin, so our skin becomes more susceptible to it. If they have a past medical history of pressure injuries or any other wound, like arterial wounds, venous wounds, diabetic wounds, burns, it can lead them to getting pressure injuries. Any type of disease that obstructs blood flow. The big one for those sacral wounds is urinary and fecal incontinence. Why do you think urinary and fecal incontinence? I mean, they always change their briefs right away, right? As soon as they've gone to the bathroom, they just immediately change their brief, right? Especially in some of the nursing homes where they may not get, Kaylee Anderson level of care, right? Where Kaylee's in there instantly taking care of all her patients. But some of the nursing homes, especially around town, the Kaylee care, exactly. Think about it. When you're with your patient, you always want to give them the Kaylee care. There are some nursing homes around town that I've been in that I'm like, man, this patient needs change, and they haven't been changed in quite a while, right? So that brings up a good topic. Why do you think sometimes nurses don't change patients? Why do they leave a patient sit in a wet brief or a dirty brief? Understaffed, okay. They don't think it's their job. There's a big one. Yeah, there's another one. Somebody who's that Renee said, because they're going to do it again. I love that excuse. And money, maybe, right? But the Renee said that one, and that one I've heard that one before, and that one bugs me. Well, he's just going to pee in his diaper again. Well, what if that was you? I always love asking that to those nurses. What if that was you? Would you like to sit in a wet diaper for 4 hours? Well, no. Then why should he? Right? What if the patient's being ornery and just is not, not obeying everything you tell them to do? They're just being kind of crabby, right? Yeah, payback, Dylan says, exactly, right? So that sometimes can be a negative effect. But so now they're sitting in urine, they're sitting in, fecal incontinence, and it's never usually solid poop they're sitting in. It is awful, Eric, you're right. But it's never solid poop they're sitting in. It's always, especially if you go to physical therapy, it's that nice, runny, gets all over the place poop that they're sitting in. I don't know why they don't leave them, they poop regularly, they'll take care of it, but runny diarrhea, nope. Decreased mental awareness can cause pressure injuries, right? If maybe the patient doesn't know they're having a pressure injury. Obesity. If I'm really obese, where could I get pressure injuries that you might not think of? Like Erica doesn't think about this very often. Actually, all of you guys don't really think about this very often. Yeah, between the folds, right? What's the term for that where the belly's kind of rolling over? What's that area underneath? What's that called? Muffin top. Right? It's the pannus, right? Dunlap's disease, right? Because the belly dunlaps over the belt. Neuropathy, again, that goes along with mental awareness. Fever, anemia, infections, ischemia, hypoxemia can cause it. And then pretty much most neurological diseases can lead to pressure injuries. So now we're going to start going here. So I'm just going to warn you, because we're going to start getting there. Prevention is the best treatment. If we can prevent it, we can stop it from happening in the first place. We need to educate not only the patient, but also the family and even nursing. Oftentimes, we are going to have to educate nurses, or more importantly, CNAs. I hate to say it, and I'm not picking on Kaylee here, but a lot of CNAs don't always get the best training when they first get hired at a hospital. They're kind of expected. I couldn't type because I'm laughing so hard. They're just kind of thrown in the hospital and said, figure it out. And there's the possibility that, they may not understand, they may not know the best way to move the patient around in bed, or they may not know how to prevent pressure injuries. So yeah, we can show them. And I've had a lot of CNAs that are like, man, that really teaches me a new way to do this. Thanks. And they appreciate it. But some of them will just tell me, go pound sand, but most of them are nice. Proper nutrition. Proper nutrition does not include Hershey's and McDonald's. Right? So that's eating your square meals, getting your carbohydrates, getting your veggies, getting your proteins, and hydration are important. Proper handling of the incontinent patient. If they have gone to the bathroom, it should be changed, right? Think about those of you that have kids, right? You change your baby's diaper very frequently. We're going to change the patient's briefs very frequently. Positioning. How often should we turn patients at minimum? Every 2 hours. Good, right? Early detection is the big thing. It's a lot easier to prevent a stage 1 pressure injury from becoming stage 2 versus a stage 4 going to a stage 1. And look at that segue. What do you think we're going to segue into? We're going to segue into staging, right? When we stage ulcers, there are 4 stages primarily we stage them in. Amazingly enough, those are stage 1, stage 2, stage 3, stage 4. I know they made it really easy. There are also unstageable and deep tissue, suspected deep tissue we'll talk about. It's based upon the depth of the wound and the tissue involvement, which is very similar to wound staging. They're trying to keep things simple for us. But with staging, it is specific to pressure injuries. We are not going to use this staging system for an arterial ulcer or a venous ulcer. These are specific for pressure injuries. The important thing to understand here, though, is once a wound is a certain high-level stage, it is always that high-level stage. So if a patient develops a stage 4 wound and is now healed and looks like a stage 1, it is a stage 4 pressure injury presenting as a stage 1. Does everyone understand that? They will always, no matter what, they're always going to be the highest and worst they've ever been. Now, if they start with a stage 1 and move to a stage 4, that stage 1 will convert to the stage 4. It doesn't go the other way around. We don't say we have a stage 1 injury presenting as a stage 4. That'll automatically become a stage 4 wound. And then we got to get back to stage 1. But wherever it goes, as high as it goes, that's where it stays. So if you're stage 3 pressure injury, but now it's healed, it is a healed stage 3 pressure injury. If it is a stage 4 and it's now a stage 2, it's a stage 4 presenting as a stage 2. Why do you think that's important? Why do you think we have to do it that way? What do you think that's important for? It's the ultimate important thing in healthcare. Progress too, yeah. Okay, I'll give you that. Insurance. And always expect kind of the worst, right? We need to know if we have a stage 4, if we say suddenly the patient's got a stage 1, the insurance may say, hey, wait, why did you bill me all this wound care if the patient's had a stage 1 wound? Well, no, it was a stage 4, but now it's a stage 1. Whereas if we just say it's a stage 4 presenting as a stage 1, they don't argue. Well, they still argue because insurance argues about everything, but it gives them at least an idea of what's going on. So let's say I had a stage 3 pressure injury of my inferior scapular angle, and you now see it, and it's now a stage 1. How would you put that into your notes? So I had a stage 3, it's now looking like a stage 1. Stage 3 presenting as stage 1. Great. So I want to make sure you guys get that because you're going to have some questions. I guarantee it on your boards and also on my test asking about that. Now, is it our job as a PTA to be able to stage a wound? It is not our job as a PTA to initially stage the wound. So when they're initially seen for evaluation, that's the PT's job. But once they have been staged by the PT, it becomes our job. Because it's just like manual muscle testing, right? The PT does the initial manual muscle test and says, well, they're a 4 out of 5. We have to be able to judge if it's gotten better or worse. Same thing with wounds. What do you think would be a good rule of thumb when you get a PT, though? When it gets better or when it gets worse? Yeah. Right. Any type of downslide, we kind of want to let the PT know as soon as possible, right? We've had a stage, maybe yesterday we saw little Billy, and Billy had a stage 1 pressure injury of his sacrum. Now you come in and you can see his whole sacrum, and it's a stage 4. Yeah, it's time to get the PT because something went happen between the last time they were staged and when you're seeing them. So it's always the highest level stage. So let's look at stage 1s first of all. Stage 1s are non-blanchable erythema. The skin doesn't turn white. Of intact skin, no openings of the epidermis. So that means there's no visible wound, but it is usually a red spot that doesn't turn white. And with capillary refill tests, remember, anytime we've done that, right, where we press down, we watch for it to go white and watch for it to refill. That should refill in about 2 to 5 seconds or less. If not, what could mean you're cold, right? Like if you're in a really cold room right now, sometimes it does take a little bit longer. Or maybe you just have poor blood flow. The stage 1s may appear purple, blue, or violet. They may or may not be sore, right? A lot of times when I've encountered the stage 1s, patients often think they're itchy just because they're kind of like an area where, why do you think the wound's getting itchy? What's happening in there? What chemical mediators are coming in? My enes, right? My cytokines, my histamines, all that. They're coming in to kick up that inflammation, right? Stage 1 pressure injuries may only be superficial, or we may mistake them for a stage 1 and they may have a deeper wound underneath them. So we have to be really careful when staging them. All these pictures are nice stage 1s, right? So we got this one over here. You can see that's nice bright red area. Here we have one. So where do you think this one on the left is? This one over here. Where's that one at, do you think? If you had to hazard a guess. If this is the butt crack, this is the fold in the lower back. What bony prominence is between the back and the butt crack? Ischial tube's gonna be down here. Yeah, PSI, it's probably a PSIS, right? I'm guessing. I don't know. I'm assuming that's what this is. That could be a whole butt crack, and that could be an ischial tube. Maybe I'm reading it wrong. Then we got, what do we got over here? What kind of pressure injury do we got on there? That middle one. That one's, I know what that is. Yeah, that's in the Achilles, right? That's the heel. That's one of those heel ones. Ladies, sometimes you will get pressure injuries like this from wearing what? Heels. Yeah, Dylan answered that quick. Good job, Dylan. So from wearing heels, pretty frequent. Been there, done that. I love it. Yeah, they're not very comfortable to wear. I'm just saying. It's finding one to fit my feet. Soccer. Okay, yeah, actually, there's a real good point. Good point, Jesse. Either soccer cleats or football cleats. Yeah, it's really common to get those sores back there, right? I don't know why, who designed them and why they put that back of that shoe like that turns into a piece of metal almost. But yeah, it's horrible. And of course, we got the classic, right, upper sacral pressure injury here. So stage 1 is non-blanchable erythema. Is there an open wound with the stage 1? Okay, so that means, what do you think stage 2 has? Yeah, it's starting to open up. Good. All right, so we're going to finish off stage 1 here. How do we treat it? Well, patient should be repositioned, right? Keep the area clean and dry. Avoid massaging over the bony prominences. Big importance. Provide adequate intake of protein and calories. Maintain current levels of activity or increase if possible. Positioning devices to help them. Maybe we need to give them a wedge to keep them from rolling over. Keep the head of the bed as low as possible to reduce risk of shearing. I don't know why this is, but in every hospital I've ever been in, little Millie likes the head of her bed up high, right? She's sitting in, whether it's nursing home or whether it's a hospital, she likes her head of her bed up high so she can watch Jeopardy or Price is Right. And then you come back to see little Millie an hour later, and where's she at? Kaylee should know this. Where all your patients always end up when they raise that head of that bed? Yeah, down. They're usually scrunched up at the bottom of the bed, right? Their feet are against the bottom of the bed. And like, I don't know how I ended up like this. And you scooch them up and you kind of help shimmy them up the bed. And then about an hour later, you come back and they're all the way at the bottom of the bed again. Right? Well, patients that have pressure injuries that are stage 1s, we want to protect them from becoming stage 2s. When's a good idea for changing the sheets on a patient? At least how often should sheets be changed? Yeah, every day, right? So this is where I time, and when soiled, yep. This is when I time with my nursing assistants. Because if Kaylee's my nursing assistant, I'm gonna come to her and say, hey, Kaylee, I'm gonna get John up in about 15 minutes. And we're gonna do some walking, we're gonna do some exercises out of the chair. I'm just letting you know because that might be a good time where you can get the sheets changed while he's out of the bed. Now Kaylee doesn't have to worry about getting John up to change his sheets or rolling them all around while to change his sheets. I got him out of the bed. She can come in, and I've seen some CNAs and some nurses that can change those sheets in like 3 seconds flat. It's like a NASCAR event. Like they come in, sheets change. I turn around, I'm like, oh, okay. But they really appreciate that, because if you get the patient out of bed, they don't have to worry about that patient then. You're worrying about the patient. The only thing they have to do is put sheets on the bed. And man, they love you for that. They're all but hug you. Because you're worrying about the patient. They don't have to worry about that patient at all. They just have to come in, change the beds, and get out of there. And a lot of times they come in, they change sheets, they put a new bottle of water in there, and they're out the door. So, but the key thing also is make sure they're wrinkle free. Right? A wrinkle is an area that can develop a pressure injury. And get a patient out of bed as much as possible. If they can sit up in a chair, have them sit up in a chair. We know that's better. Now we go to stage 2s. Stage 2s are superficial injuries that often present as a small crater or blister. They may be shallow and may have a reddish base. So they are considered a partial thickness wound when we talked about wounds before. They typically involve the epidermis, but they can involve down to the dermal layer. So stage 2 can go down to dermal. The key thing with the stage 2s are no fat or subcutaneous tissue are visible, and definitely no deeper tissue. So no bones, no ligaments, no tendons, no organs, right? And that's not visible. So if you still got intact skin, nerve endings, stuff like that that you can see, that's probably a stage 1 or stage 2. Granulation tissue, maybe not present. Sloth and eschar, typically not present, right? They can be, but that's usually when you get deeper. They may have intact or partially ruptured blisters, and they can also be considered stage 2s. So it may not always be a result of pressure itself, but it's usually a problem with skin tears, right? But something like what this is saying is something like an arterial wound looks a lot like a stage 2 pressure injury, but arterial wounds aren't pressure injuries. They're caused by lack of blood flow. And a lot of times stage 2s are pretty sore, right? Patient's going to be complaining about these. And why are they saying that? The body's basically saying, hey, idiot, got a wound down here. You got to take care of me. I want to step back 1 second because I forgot to mention something back here in stage 1s. For stage 1s, what kind of dressing do you think we're going to use on stage 1s? What kind of dressing? So what kind of wound dressing? There are typically 2 different types of dressings we use, not Italian and ranch. Yeah, we may use a hydrocolic, right? So typically on a stage 1, we're going to use either a foam to give a little bit of cushioning if it's really kind of bright red, but a lot of time we're going to use films. And films I know you've all encountered before if you've ever had an IV put in. Film is that plastic they lay over it. It's usually by Tegaderm is the company that makes most of the films that are out there. And films are just a clear piece of plastic. Why do we think we're going to use a clear piece of plastic over it? We'll talk about that in a second, Tyler, actually. Why do you think we might use, okay, to keep them dry, that's one part, good. What else does the film allow us to do? That maybe the film that allows us to do that the foam might not. Look at it, yeah. So the film allows us to visualize the area entirely. The other thing that film does, if maybe I have it on my ischial tube, right? And I put that film over it. Now when Tyler comes in and slides me around in the bed, I'm not sliding on the ischial tuberosity. I'm sliding on it really, and usually the film, the outside of it is usually pretty super slick. So that reduces the shear force on that. Now, why would I use a foam versus a film? It's a great question. So foam, meaning literally like it sounds, right? Like piece of foam. If the area is really, really red and angry, Tyler, right? I'm going to use a foam, right? If I look at that area and I'm going, man, this thing's 2 seconds away from becoming a pressure injury type 2, right? If I'm there, that's when I'm going to use it. I thought somebody was talking. It's me talking. So it's a fine line. I usually use films the clear films on most of my stage 1s because I want to be able to see it. I want to make sure that I know as soon as it changes. But I may use a foam on something like that heel wound down here. I'm probably going to use a foam on that heel wound for cushioning. But something like this in the back, you know, this one over here. So this heel wound, definitely probably going to go foam. This one over here, I'm probably going to put a square film over it just so I can keep an eye on it. It's not too angry yet. And again, that's something you'll get with experience. So back to stage 2s now. So here comes some pretty pictures. All right, so we got some stage 2 wounds going here, right? Pretty. What should we do to that blister? No. No. We don't pop it. If the PT decides to pop it, pop it. But for the most part, we're going to cushion and protect it. Justin's like, please, can I pop it? See, these are the people I knew. Because we don't have to see it. That would be my thought process, Jared. Exactly. I'm like, I don't want to see that thing. Dr. Pimple Popper is not my show for sure. All right, so we've got kind of a shallow crater. I think this middle one has an alien in it. I'm not sure. Once you see it, you won't be able to unsee it. You see the alien growing in the wound? This guy was taken up to the mothership and tested. All right, so we got specifically these 2 wounds over here. How do you think we're going to treat these? First of all, we're going to clean them, right? Honestly, we only have to clean them with some saline, just kind of dab it out, right? When we do the dressing on these type of wounds, the goal needs to be hydrated, keep it moist, good, and keep it covered. That's our main goal. So for these 2 small, shallow type craters, a lot of times, all I'm going to opt for is your basic giant Band-Aid, right? One of those, the dressings that have the actual piece of gauze attached to them. I'm going to moisten that gauze up. I'm going to moisten the wound bed, and I'm going to put that kind of giant Band-Aid down. The goal should be fill as much of that dead space as possible and keep it moist. And again, usually we're going to try to change that dressing as often as possible. But our goal is to keep this from going worse. Now, that middle one I'm a little concerned with. Right? So this middle one here that I'm looking at, I want to erase that stuff just so I can kind of draw some more on it. The middle one, what I'm a little concerned with is this. That white area, that white ring. Why do you think I'm a little concerned with that? Yeah, pretty much straight up Band-Aid. We'll talk. I've got the video about the different dressings in a little bit. What do you think I'm worried about that? Could be white blood cells fighting something in there, right? The other thing is I'm going, that might be crusting over. And that might be the start of that kind of getting a little bit of eschar out there on the wound edges. And we might have to let the PT know, hey, Bob's got some of that nasty gunk on the outside of the wound. We might have to take off then. We definitely have to get that sloth out, right? The alien's got to go. Look, the alien's even got a monkey tail. We got to get that kind of sloth out of there, which we're just going to get out with just some gentle saline. Just kind of clean it out. And also, with that little bit of sloth in there, that kind of tells me this might just be the body fighting a little bit of an infection. The outside of the wound bed, cherry red, angry, that may be normal depending on how soon that wound is. I guarantee this one on the left, change my color again, this one is sore, right? You can see exposed hair follicles in that one. That one's sore, right? That patient's not having a good day with that wound. The one in the middle, maybe, but definitely that one on the left is definitely one that the patient's pretty sore with. So stage 2, we're getting down into that epidermis and through the dermis, right? For treating a stage 2, cover, protect, and clean. That's our main goal. With quick attention, stage 2s can heal pretty rapidly. right? Think about it for a second. You've all gotten pretty bad cuts, and as long as you've taken care of them, they've healed. For the most part, most will heal pretty easily. With people in nursing homes and hospitals, proper nutrition is this. Once we get to stage 2 or higher, proper nutrition is vital. If they do not get enough nutrients in, they will not heal. And if they progress beyond stage 2, it's because we didn't aggressively attack them. Right? The other thing we could do is if we have a patient that's got a stage 2 that progresses, maybe they're not taking care of it, right? Especially if they're in an outpatient world. All stage 1 precautions should be followed, and sheets, clothing, everything should be dry and wrinkle-free. Let's say that I have a stage 2 pressure injury on my heel, or maybe back on that Achilles tendon area again. And now I've got dressings over it. So I've got your standard kind of like giant Band-Aid style dressing. What kind of socks would you recommend I wear? Other than clean ones. That's a big battle with patients. Clean socks, please. Would you recommend like nylons? Would you recommend cotton socks? What do you think? Anyone have an idea? Maybe compression socks. Typically, we're going to recommend like just your standard white cotton socks, or if you get black ones, black cotton socks, fine. Why do you think we recommend cotton socks? Anyone have an idea? What do cotton socks give you a little bit of? Yeah, they can keep the area nice and warm, good. They let a little bit of air into the actual area around the wound where maybe the Band-Aid's not. And movement, and also a little cushioning. Yeah, right? The cotton socks definitely, for those of you that have ever worn nylons, are really not comfortable wearing nylons. Or so I hear. I've never worn nylon. Actually, I have a pair of nylon dress socks and I hate them. But just, you don't get a lot of cushioning with them. You don't need the compression because we're not trying to keep swelling out of it, right? But just your standard. And the other reason I'll tell patients, I'll say, you know, if you can, wear cotton socks, because if for whatever reason that dressing should seep, maybe something gets out around the dressing, the cotton sock will absorb that, right? Whereas if you have something like a nylon, a lot of times when that gets blood or something on it, kind of sticks to the area. We don't want that. We just kind of want to get anything that's out of there out of the way. All right, now we're going to talk stage 3. Deep tissue insult that presents as a deep crater or may have tunneling or undermining. Oh boy. So stage 1, no wound, just kind of unblanchable redness. Stage 2, epidermis, dermis. Stage 3, epidermis, dermis, subcu tissue. So now we're getting down into the adipose and your fascial layers, right? Still can't see bone, still can't see tendons, still can't see organs, right? So stage 3 is just before we get down to that layer. A lot of times there's going to be sloth and necrotic tissue present, and will typically require debridement. And just remember that dead tissue breeds dead tissue. If you notice it, it needs to go. That means you need to let the PT, hey, Bob's got some eschar in the top of his wound. Can we get it debrided? The PT will be like, yes, I can debride that wound. Because usually PTs that are wound care specialists really enjoy, for whatever reason, picking at wounds. They are maybe painful, right? But towards the more serious side of a stage 3, they're going to start becoming less and less painful. Why do you think? What's happening to the tissue underneath? Yeah, the nerve's starting to die off, right? Especially if you're getting down to a subcu area, the nerves may be gone, right? So as it progresses, sensation will continue to decrease. But with most wounds, remember, it doesn't really matter where your wound is. The actual wound itself, usually pretty insensate for the most part, unless the nerve's still active. The edge of the wound's pretty sensitive. So when you're in there cleaning them out, be aware of that. Okay, I'm getting this. When I get over to the edges, I'm a little bit more gentle because that's where they start jumping. No bone or deep tissue visible is the important part with stage 3s. Now we're starting to look at some pretty wounds here. Right? So now we're starting getting down into that stage 3, that fat, peekaboo wounds. Yes, right? How do I know that I've got a stage 3? And I see that kind of, especially on this, let's look on this side over here. On this right one, I'm starting to see that sub-Q fat. Right? Here I got some sub-Q fat here. This one's got some nice sloth and exudate along with some sub-Q fat. That means I'm down to that stage 3. Now, if I have a stage 4 and it looks like a stage 3, great. I'm not going to say anything to a PT. But I had a stage 2 yesterday and now it looks like a stage 3. Time to get some PT. What do you think some of our goals for wound care for these are going to be? Obviously, keep it warm, keep it moist, keep it covered. That's going to be our standard for all wounds. Keep it secret, keep it safe. No, don't keep wounds secret. You got to tell everybody about it. Yep, that's some sub-Q fat. It's some dried out sub-Q fat. Yes, Tyler. Okay, none of these have stitches. Why do you think we left these open like this? Because they're pressure injuries and a lot of times they get worse. So we got to let them heal naturally. And if we stitch them closed, there's a good chance it's not going to heal and it's going to end up, we're going to end up with a gaping hole underneath. We got to let the whole area fill in with granulation tissue first, the cratering, yeah. So one of the things we're going to do as wound care is we are going to pack these babies, pack it in, right? How much is too much packing? If it's bulging, it's too much packing, right? If it looks like they're trying to sneak stuff into a movie theater, you got too much packing. It should be just kind of right and smooth along the skin surface. You need to pack all areas of the wound. I'm looking at that middle one and I see this area over here. What do you think that area over there is developing? Because I'm guessing if we were to stick our little thing, yeah, I'm guessing that's a tunnel going that way. That means we need to pack that tunnel too, right? We need to pack everything in here. This wound's got some undermining. Wound 1. Kind of looks like the eye of Sauron, doesn't it? It's staring at you. But this one's got some undermining. What about these edges? Let me erase these real quick. Those edges look a little bit epibolic to you. Remember epibolics where it rolls under? See a little bit of that with that wound? So PT may have to trim that back some. But we're going to pack this in. And what we should see with all of these wounds, we pack this in with gauze. Pack, 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 pack. As we progress, we should see less and less packing being used because granulation tissue will start laying the matrix down and will fill up. And those wound edges will get as close as possible and they'll heal. All 3 of these wounds are probably going to leave nasty scars. They just are. I mean, pressure injuries typically leave really nasty scars, unfortunately. It's pretty rare that they heal and look perfect and beautiful. Right? So lovely stage 3. So again, stage 1, non-blanchable erythema. Stage 2, we got an open wound, maybe down to the dermis. Stage 3, we're now down to that sub-Q fat layer. So goal of stage 3 and stage 4 wounds is to properly debride and dress the wound cavity, create or maintain moisture for optimal healing, protect the wound from infection. Wound bed should be covered, moist, and warm. That makes them happy wounds. Yep, we're gonna, so I'm gonna talk about that once we get through kind of all those stages here. We're gonna talk about that in a second, Dylan. So once we're gonna go on break and then we'll talk about that. You do want to document how much packing. Properly unload the pressure area if we need to. If I've got a stage 3 pressure injury in my sacrum, I might give them one of those funky donut pillows to sit on. Just because it removes a little bit of pressure. At stage 3, we definitely have to be focusing on that nutrition. You need to tell Millie to eat her vitamins. We're going to finish stage 4s and then we'll take a break. Stage 4s are deep tissue insults, usually with extensive necrosis and a lot of tissue loss. They often have undermining multiple tunnels or fistulas. It's a full thickness wound involving dermis, epidermis, sub-Q tissue, and underlying tissues. So bones, ligaments, tendons, joint capsules, muscles, organs. It is not uncommon to see underlying organs in a stage 4 wound. My very first patient I ever did wound care on, never forget it. It was third week into being a PTA. I was working the weekend shift and somebody says, does anyone know how to do wound care here? And I'm like, well, I did it in school. And I'm like, congratulations, you're the wound care PTA. Okay. Like, here's your first patient. And I remember we had a, we didn't call them techs. What did we call them? We had basically nursing assistants that helped us. And the nursing assistant goes, what patient is that? I'm like, 223. And she's like, oh, I'm so sorry. Whenever a nursing assistant says that to you, get concerned. So I went and saw him, and he had a small pimple that had developed on his scrotum. That pimple got infected because he had peripheral neuropathy, including his scrotum being neuropathic. You couldn't feel it. He evidently scratched that pimple, popped it open, and it got infected. And he ended up getting necrotizing fasciitis of the scrotum. And so when I went to see him, he had no scrotum. Three quarters of his penis had no exterior tissue, had no epidermis or dermis. And he had a gaping cavity in his lower stomach. Literally, I take the gauze wrap off and I can see vas deferens. I can see all of the sperm ducts, everything. It was like an anatomy lesson. There was absolutely no skin whatsoever. That would be a stage 4. Right? I could clearly see everything down there. Right? And not only that, but his little stomach wound, you could look up under his stomach wound and see the bottom of his intestines. It was a cool wound to dress. I'm glad he was in a coma. He was in a medically induced coma, because I guarantee if he wasn't in a medically induced coma, the wound care I was doing to him, he probably would have passed out at some point, because I wasn't on the verge of passing out doing it. It was not a fun wound. But again, if you can see underlying structures, bones, ligaments, tendons, blah, 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 it's probably a stage 4. The edge of the injury usually have sensation, but the wound itself is usually insate. Nerves are dead, right? And it could lead to worsening. For that guy, it got a lot worse, right? Because he couldn't feel the area, so he didn't think he had a problem. And I guess he didn't really start realizing it till skin started falling off. The doctor's notes says something about, patient noticed it when most of scrotum fell off into underwear. That was when he noticed he had a problem. That's not terrifying at all. But yeah, so be aware of that. So let's look at some stage 4s here. So we can see definitely got some underlying structure showing in these pictures, right? And for those that can't figure it out, what is that middle picture a picture of? What is that? That's an E. Yeah, you can see the LCLs and stuff like that clearly displayed. All that skin is gone. I think that was a motorcycle accident. I think that's where I got that one from. Here we got some bone over in the left picture, right? I think this is organ, if I remember correctly. I forget where I got that picture from. But yeah, definitely got some problems there, don't we? So stage 4, we're going to have to protect that underlying tissue, because the last thing we want is that underlying tissue to get infected. let's say in that first picture where we got that bone and that infection gets into that bone, the patient develops osteomyelitis and could get a lot worse. So we have to protect the underlying structures when we have a stage 4. Then we have to keep the wound warm, moist, happy, and covered. So we're going to pack her in and we're going to get rid of everything. Looking at this middle picture, do we have a lot of tissue that we're probably going to have to debride on the middle picture? Do we see a lot of necrotic tissue in that middle picture? Look at the top of that knee. That don't look like healthy tissue, right? A lot of that tissue is going to have to come off, right? More than likely, the PT is going to come in. Yeah, absolutely. Why? So even this patient here, let's see, we're dealing with this knee patient here. Why would we want to keep that patient moving, even with the wound as bad as that is? What's going to happen if we don't keep them moving to the skin there and the tissue? It's going to bind down. So you got to understand, yeah, promote blood flow. What you also understand here, also, Renee, is when we talk PT, we've got to talk wound care PT and regular PT. They may not be done by the same therapist, and oftentimes they're not. Right? So I may go see this patient, like maybe I'll go see this this knee here, and I'm going to go and treat the wound. So I'm going to clean it out. I'm going to put a proper dressing on it. I'm going to make sure it's all nice and clean. And then you might see them later to see them for regular PT. But all of these patients, I want to have regular PT on no matter what. If they have wound care, they should have regular PT. Because the wound care is only going to do so much to get pressure relief, get blood flow. Could do, absolutely. Yeah, even passive range of motion is better than nothing. For this patient with this knee, I actually wouldn't mind having a CPM for them. And you know how much I'm against CPMs. I don't really care for them. It depends. So it's going to depend upon, CPM is that continuous passive motion machine, the machine that's going to move them through the motion, right? It's going to depend. Let's say and so like my patient that had the scrotum missing, definitely probably not going to have a lot of PT. He was in a coma, not going to do much. And sitting him up at the edge of the bed is probably going to be torture, right? But any of these patients we have here, even the one that's a pressure injury on the sacrum, or I don't even know where that, I forget where that right one is. I want to say it's lower stomach. Even those patients, yeah, I want to get them up and moving, even with a nasty wound like this. Because what's going to happen is, and this is really typical in the nursing home, patient gets a really nasty ischial tuberosity pressure injury. And because they have that pressure injury, they don't get out of bed. And because they don't get out of bed, that pressure injury either A, gets worse, or B, they get another one. And now they've got 2 pressure injuries. And so now they're less likely to get out of bed. So because they've got 2 pressure injuries, they get another pressure injury somewhere else. We have to convince them that just because you have a wound doesn't mean you can't get up. Right? Think about it. If we do like when the docs did my cervical surgery, they gave me 2 wounds. You know, within 12 hours of my surgery, guess who was in my room with me? PT. They were in, they checked my wound. They're like, okay, let's get up and moving. Let's get dressed. Because we know that no matter how bad the wounds are, the better they move, the more they'll get blood flow to that area, the more likely it is to heal. Gets you hyped. Yeah, I don't mind. I actually like wound care because I don't have to lift patients. The most I usually have to do is roll them around in bed. And I don't mind that. Although I will say doing wound care, especially on the sacral ulcers, I have to change a lot of briefs and clean patients quite a bit. Just because they usually are sitting there and poop. So with stage 4s, same thing. All stage 1 through 3 precautions are there. The main thing here with stage 4s is if the extent of the pressure injury or other factors prohibit it from healing properly, surgery may be needed at this point, right? They may do curettage, they may do excision, or even cauterization. It may get to the point where they're like, okay, you know, we have to, and, you know, maybe I've got that pressure injury on my knee and there's nothing I can do for it and it gets infected, it might just be better to amputate the leg, right? I've seen a patient that came in with a really, really bad infection in his midfoot, and the patient just wanted the back of the foot cut off. And the doc says, well, I can cut the back of the foot off, and then in 6 months, you'll be back with me and I'll cut the next part of the foot off, and then I'll disarticulate your ankle, and then I'll cut you about mid tibia, and then I'll cut you about higher in the tibia, and then I'll take your whole tibia. Or I can take you at mid tibia right now, and we can stop the infection from getting worse ever. And that'll be your last amputation, as long as you take care of it. So sometimes amputation may be needed in this case, right? And you got to think about that. Let's say I get frostbite on my first 3 fingers, right? So I get really, really bad frostbite on these fingers. And just think about it yourself. You get really bad frostbite. Would you rather lose these 3 fingers and maybe even portion of this hand, or would you rather lose the whole arm? I'd rather lose that small area and live that way. At least I can function, right? Rather than losing the whole arm. But we can take care of that and do proper wound care and make sure that it doesn't progress. We are going to be the guardians of the things getting worse. All right. So let's take a break here. I'm going to stop sharing. We're going to pause recording. And so we're back from break. All right, so I'm going to ask a question here and ask you guys to figure out what stage the patient is in. So I'm going to type it out on screen so that we can all see it. Let me get my little typer texter thingy up here. All right, so let's go with the black font because that'll make it easy. Let's say the patient has a shallow crater wound down to the epidermal layer. With 20% eschar present. So you can see down, it doesn't extend down into the dermis. And it's got some eschar. So I got a stage 2, I got a stage 2, that's stage 2. We know it's at least a stage 2 because we've got an open wound, right? We got at least that part. Do I have any other guesses? Here's stage 2, what we're all going with. Okay, we're gonna go stage 2, and final answer, stage 2 is what you're saying. Well, that's a trick question, Bob, because I tricked you a little bit. How did I trick you? The eschar. I did that on purpose. If it was just a shallow crater wound down to the epidermal layer, you would be absolutely correct. The shallow crater down to the epidermal layer would be a stage 2. But because it has eschar, what we're going to find out, and I'm going to clear all the drawings here, that what we will call that is an unstageable wound. Why do you think we're going to call it unstageable? Because we can't what? Other than we can't stage it. Don't say that. We're going to call them unstageable because we don't know what's under that eschar. Right? There we've got a residual limb that's got a nice chunk of eschar on it. You know, anytime, and this is the reason I did this is because your boards love this question. They love it. Like, no, I'm going to trick all kinds of students with this question. No, this is my glory. They'll throw a question in that is very clear. It'll either be a stage 1, stage 2, or stage 3 pressure injury, but they'll say it has eschar. And because it has eschar and you can't see what's under the eschar or under the sloth, it's unstageable until we remove that. Because what happens if that shallow crater down to the epidermis, and then we peel back that eschar by doing debridement, and suddenly we see bone? We're automatically at a stage 4 then. Right. And we want to make sure that when we stage it for the first time, we stage it appropriately. And it may be the PT comes in and sees that it's got eschar, and we just can't take that eschar off yet. It's just too delicate of a wound. We can't pull that eschar off, so the PT is going to call it an unstageable wound. What that basically means is, I'll get back to you. I thought that would make you guys laugh. So here, because I just read it. Right, so unstageable pressure injuries are ones we know the depth. We don't know the depth. It's unknown depth. Full thickness tissue loss, base covered by slough or eschar. It's an injury bed. The aim here is to remove that non-viable tissue, and we'll debride it. The main idea here with unstageable is if you can't see the bottom, you don't know if Cthulhu is there. And so we don't really see how bad it is. If the PT says it's unstageable, it's unstageable. We just go with it. Now we get that eschar off. It may only be a stage 2. Maybe that's the same layer. It's just down to that epidermal layer. We just had to get it off. Great. Now it becomes a stage 2. But it could be a stage 4. Now, let me change that question really quick here, just real quickly. And so now, where's my little letters at? There's my letters. So now we have a pressure injury. Oh, I was not on the right keys there, was I? To the, I don't know, let's pick lateral malleolus. Epidermis, dermis, sub-Q, fat loss with exposed inferior aspect of lat mal and 30% eschar present. Now what do we stage it? Yeah, right? Now that eschar doesn't matter. Why does that eschar not matter? Yeah, because we already see the bone. Exactly. Right, we know it's a bone. Bone says stage 4. Can't get worse. Right? We could pull that off and there could be more bone there, or it could be epidermis. Doesn't really matter. Right? So if we can see the bone already, stage 4. This is the way your boards will try to trick you. Like I said, they will give you a stage 1, 2, or 3 with eschar. And you'll look at it and be like, oh, look, it says it's down to the sub-Q layer. That's got to be a stage 3. And then it says with eschar. And you're like, brain, stop. Unstageable. But if you have a stage 4 with eschar, it's always a stage 4. It can't get any worse. Does that make sense to everybody? Like that one on the bottom down here, 100%. We have no idea what's under all that slough. Right? It looks like somebody just talked the loogie all over that wound. Right? Until we clean that off, we have no idea how bad that is. And I'm just looking like even at that one point, you can almost see at this point here, you can almost see bone, can't you? It's almost like you can almost visualize the bone there. So there's a good chance we're going to get bone once we get all that slough off. Slough off. Maybe I should make a wound care product called that. Slough off. It's used in wound care. No, I thought it was funny. This is why I'm not a very big hit at parties. All right, so now we've got stage 1s. Stage 1s, unblanchable erythema. Stage 2s, open wounds down to the dermis, no deeper. Stage 3s, down into the sub-Q fat, no deeper. Stage 4s, exposed stuff underneath, bones, tendons, ligaments, organs, stuff like that. Unstageable means we don't know what's down there yet, so we can't be a stage in them. Cthulhu may be there. Just be aware of that. The other one we have is what's called an SDTI, or a suspected deep
tissue injury, right? Again, this is another one where we don't know what's underneath. They typically look like purple maroon area of local discoloration of intact skin, can be a blood-filled blister. Blister may have eschar over it, may have a dark wound bed. With a suspected deep tissue injury, the only thing we can do is wait and see. The difference between an SDTI and a stage 1 is in the way it presents. Typically, your stage 1s are going to be non-blanchable red erythema. If you've got something like that heel there where it's black, that's not erythema. There's something going on under it. Why is that turning black? What's under the skin? Blood, necrotic tissue maybe. We don't know. Skin's intact, but something underneath is dead. A lot of suspected deep tissue injuries look very, very much like a really, really bad bruise, right? So we're going to protect the area. We're going to make sure that we watch it. We got to watch for maceration, because if that skin is intact, we don't want that skin to not become intact. And if they have a suspected deep tissue injury, these are the bad ones that can sometimes become osteomyelitis quick, because let's say I've got it like at that malleolus, or that malleolus, but that calcaneus up there. My brain just drew a complete blank. With this wound up here. And maybe I do have an infection under there. Maybe I stepped on a needle, I don't know, something. And I've got an infection on the skin. The skin is intact. But underneath there, that stuff could be dead, and that could be infected. Well, if the skin is intact, the infection can't get out. So that means the infection only has one way to go, and that's in. And so that means that infection is going to start attacking the bone next. So we're going to watch this. It may end up being that the PT or a surgeon or a doc or something like that may just come in and say, I don't know what's going on here, so guess what they're going to do to that skin? They're going to excise it. Or they may excise a small portion of it so they can see what's going on underneath, right? So excise where they cut it out, right? So on this, they may come in and say, well, I'm going to take, they wouldn't take it back here probably because that's a really big bony prominence. They may take a small square of skin right there. And all they're doing is opening a window, right? So now they take and they cut open that small piece of the skin, they open it up, and all of a sudden, as soon as they peel that skin back, it smells like rotten meat. We know we've got an infection there. Or maybe it smells sour. There's an infection in there, so we know that we got to treat it, right? Or maybe they open it up and they just realize it's just a bruise. Well, now we've only got that little small area to treat, you know, versus the rest of it. So an SDTI can be really dangerous if we're not careful. And again, this is not something like your kids would get, right? Your kids are just going to get bruises. Could a bruise turn into a suspected deep tissue injury? Sure could. Right? If it's really bad enough and it swells with that swelling with the blood and everything in the area, yeah, that can start pushing the underlying tissue and start causing problems underneath. There have been I've seen a couple kids come in specifically in sports and stuff like that, or really high contact sports, where they actually bleed the bruise. So they'll puncture the bruise just a little bit to let the blood that's underneath kind of seep out, because that way it relieves pressure on the underlying tissue and doesn't kill maybe a muscle or something. Yeah, I think they did it in Rocky. I think you're right. They do that in boxing a lot. And that, to me, that's not a good idea, right? You probably have seen it where they get a swollen eye and they just cut the eye to let it bleed out. I don't know why they do that, but I mean, whatever. I mean, I guess the eye makes sense because the eye could be a really sensitive area of swelling, right? All right, so we covered pressure injuries. That is it for pressure injuries. The major thing about pressure injuries is they are preventable. So pressure injuries are preventable. Pressure, prevent. Pressure,
Prevent. Now we're going to talk about arterial, and that doesn't mean that arterial are not preventable, but they're not typically caused in the healthcare setting. So arterial wounds are areas of decreased or insufficient blood supply leading to ischemia. A lot of times it can be from arteriosclerosis, atherosclerosis, trauma, an emboli, poor blood perfusion, can be from peripheral vascular disease, right? They're also known as ischemic ulcers, right? So arterial wounds are going to be ischemic ulcers as well, because once the area stops getting blood, it dies. What are some risk factors for getting arterial wounds? Elevated LDL is one of the major ones, right? So you have hyperlipidemia. Smoking. You're going to find for arterial wounds, diabetic wounds, venous wounds, one of the major risks can be smoking. Smoking is bad. Diabetes can be a problem with arterial wounds. High blood pressure, trauma, advanced age, vasculitis, where you get inflammation of the blood vessels themselves. Renal failure could be a problem if the blood's not being filtered enough and there's infection and crap laying in the blood, right? Limited joint mobility. What if I'm not able to move my ankle? Definitely could end up with some problems there. Or maybe a family history of arterial problems. So you've got a patient that mom had arterial wounds and dad arterial wounds. Are they likely to develop it? Probably, yeah. There's some familial linkage there. So what do they look like? We're going to talk for the next couple types. So for arterial, venous, and diabetic, we're going to talk about what's called the 5PT method. Now, it doesn't stand for the 5 physical therapies. Literally the 5 Ps and the 1 T, the 5PT method. So what do arterial wounds look like? The first P is pain. Arterial wounds are extremely painful, right? Because what is happening in the case of arterial wounds? Tissue's dying. When tissue dies, the body screams, and that's pain. Position, where are they found? They're rarely above the knee, which means they're typically in the lower leg. And you're going to find most of our wounds are going to appear in the lower leg. They'll occur on the toes, the lateral anterior surface of the lower leg, including the malleolus. So if we're talking lower leg on that lateral anterior side, lateral or anterior side, those are going to be typically arterial wounds. When we talk toes, it's typically going to be the top of the toes, not the bottom. We'll talk about what ones appear on the bottom then. They appear like round, so presentation is the next P. Round, pale tissue. There's possible necrotic tissue as it's dying. There's almost no bleeding because, again, blood flow is cut off. They have what's called a punched out look. It almost looks like somebody took and just sucked out that piece of skin. And usually the base of the wound bed is necrotic, which means we have to clean it out. The peri-wound, the area around the wound, is typically thin and shiny. They have no hair typically in that area. Why is the hair gone? Why do you think the hair's fallen out in that area? What do you think with an arterial wound, there'd be no hair? Well, with no blood, yeah, follicles are gone, right? With no blood, the follicles die, right? So the follicles are gone. Usually has very well-defined wound edges, meaning it's pretty easy to see the edge of the wound. It's not like going, oh, I don't know if that's a wound edge or if that's still healthy skin. You can clearly see in that top picture up there, there's definitely a nice edge to all those wounds. Pulses, so that's the 5th P. It's reduced, minimized, or absent. Well, that makes sense. If it's an arterial wound, blood flow is reduced. And temperature, they are hypothermic, which means they are what? Hypothermic means cold. Yeah, cool to the touch. Exactly, right? And that makes sense. I don't have blood flowing to the area. It's probably going to be a little cold, right?
So if it's left untreated, though, the key thing with these wounds is they're left untreated can lead to serious complications. Infection. Yes. What about around it? Even the area around it's often cool. Good question, Dara. Right? So even the area, because you got to think about it. If that one area is not getting blood, more than likely the whole area around it is as well. They typically won't show signs of your normal inflammation. So a lot of times your cytokines and your histamines don't get down to that area. And if you look at this wound here, so this wound that I took this picture, I didn't take the picture, but I had a PT send me the picture of it. This is a brand new wound, like literally super brand new. Does that look like a brand new wound to you? Yeah, no, right? When you think brand new, you're thinking there's going to be red tissue all around it. It's going to be angry. It's going to be mean, right? But because it's arterial, there's not a lot of blood flow going there. So it kind of doesn't look like your typical wound that when you think about your typical like brand new wound. And it's funny, every time I ask for PTs and stuff, like, actually, this was from MedTech. One of the ones coming up I have is from PT, now that I think about it. I thought this was the one they gave me, but it's not. And you got to think about this. If we don't treat this, that necrosis is going to spread and they're going to need an amputation. We may even need to amputate even with something this small if the blood flow just can't be restored. So what are we going to do? Well, we're going to assess the pulses in the lower extremities. Compare, and are there any differences? Right? Do you guys remember what pulse deficit was from Rehab 1 that you had with Dr. Sokel? Do you remember pulse deficit? Not lack of pulse. Deficit means we have a low or reduced. So the pulse deficit is that time that you maybe take their apical pulse and you've got 60 beats per minute. And then you go out and you take a peripheral pulse and you only feel 20 beats per minute. There's a deficit there between what the actual pulse is and what you're feeling in the periphery. That would be weird, wouldn't it? Think about that. Maybe you take their carotid pulse and you've got 60 beats per minute and you go down to their foot and it's like 15. Well, that's because, like we have this picture up here, clots and plaques are reduced in the blood flow, and so those pulses aren't always getting down to it. So how do we check for it? ABI, or Doppler ultrasound is probably the gold standard, right? ABI we can use, or the toe brachial index, similar to the ABI, just using toes. Transcutaneous oxygen measurement, so TOM, the TOM. TOM is where we look at how well oxygen and other gases are perfusing in the tissue, right? Capillary refill test is a similar test. Capillary refill test we can do, right? Because we got press, let go. TOM's a little bit more specific on it. So they both show the same thing. How fast does the local area, the local capillaries perfuse blood? TOM is more specific and is a little bit better at testing than just your capillary refill test. We're only going to be capillary refill tests because we don't have the tools for doing a TOM, right? Venous fill time tests we can do. Absolute toe systolic pressure. How much pressure is absolutely can the toe take? Arteriography. And then we also have this thing, and I brought this up because there's evidently a couple of questions on this on the last boards, which is called the Burger's test. This is not how many McDonald's quarter pounders you can eat. I know, like I'd pass that test in a heartbeat. The Burger's test involves what's called the vascular angular Burger's angle. It's the point at which the foot or the leg becomes pale when the leg is elevated and supine. Right? So maybe it can go all the way to 90 degrees before it starts going pale, right? Maybe it only goes 10 degrees. The less that angle is, the more likely you're to think that there's some severe complications in the arteries, right? Let's think about it. If you're laying on your back and I raise your leg up 5 or 10 degrees and all of a sudden the blood drains from your foot, if your body can't push blood out to your foot at that 5 to 10 degrees, you've got problems. It might have come from eating too many burgers, though. Nope, we're actually going to separate those.
Erica. So we're going to talk, this is arterial only. We're going to talk about venous insufficiency next. Does that make sense? So these are just pure arterial. So that comes to the fact of, thank you, Kaylee. It's good. Gotcha. You let me know about that. Thank you. That brings a really good question. How do you tell these apart? So that's that 5 PT method I talked about. Each, they're going to look a little different. The main thing is going to be in the subjective reporting of a patient, right? If the patient says, yeah, my legs get really sore when I elevate them, you're thinking more arterial than you're thinking venous. If the blood pressures are good and, you know, pulses are pretty even on both sides and they match pretty close to the core, and we're still having problems, we now are thinking venous because it's the blood return that's the problem, not the blood delivery. In this case, it's the blood delivery that's the problem with the arterial wounds. So what can we do for arterial wounds? Well, we're going to teach patients, and this is something, I have this in our arterial, but in reality, we should be teaching almost every single older patient we encounter this. They should be doing daily ankle, foot, and lower leg checks. What I was doing when I was in the hospital and when I was in the outpatient is I would teach them to check twice a day. Once when they get up in the morning, once before they go to bed at night. You know, if you need a mirror, get a mirror, because some people can't bend over to see their feet. Some people haven't seen their toes in 20 years. So get them a mirror. But, you know, put that leg up on your thigh, take a look, make sure you're feeling around that thigh. Do you feel any area that's sore? I feel an area that's sore on my shin, but that's only because I banged it twice this weekend. Right? I'm looking for any open wounds or anything new down there. Going down to my toes, looking between my toes, on the plantar surface of my foot, right? Because we need to protect their legs and feet from infection and injury. Locate intact skin. We may have to put cotton spacers between toes for arterial and for venous and diabetic. Cotton spacers absorb the sweat from between toes. Some people just have naturally sweaty feet. I don't know if any of you have that. It's a horrible, annoying problem. I luckily don't have sweaty feet. I usually have cold feet, but I have really sweaty shins. For some reason, my shins sweat like crazy. So if you have really, really sweaty feet, yeah, don't ask. I have no idea where that came from. Like when I'm working out, the first thing that starts sweating is my shins. It's really bizarre. But if you have really sweaty feet, you might have to put some cotton between the toes to prevent that maceration. We're going to teach them localized wound care. Help them choose the correct agents for it, correct dressings. We may have to debride any of that necrotic tissue. We have to change modifiable risk factors. Smoking, changing diet, managing blood pressure, right? Exercising as much as possible would be a big thing, right? We can't change their age. We can't change their genetics, right? We can't change their race, but we can change their modifiable factors. We're going to typically tell them to avoid crossing their legs or elevating their legs if it's uncomfortable for them. Well, why are we going to do that, Mr. McKeever? That doesn't make a lot of sense. Well, we're going to tell them, because what we're telling them is don't do something that's uncomfortable. What we're really telling them is don't elevate or cross your legs, because what you're literally doing is cutting off blood flow. And when you cut off blood flow, stuff dies, and then you get wounds. We also want to avoid sitting or standing for extended periods of time. So if I'm sitting here, it's okay, but I need to be able to get up, right? Those Apple Watches are kind of a really great tool for these patients, because you can actually go in. Does anyone have those and they annoy you yet? Where it's like, it's time to stand up, right? They usually tell you it's time to stand up when it's the least, convenient time to stand up. Driving down the highway, it's time to stand up. Doesn't work that way. But we can modify those things and help them. Those watches are really great tools if we use them. But that's the thing we have to understand is we can have all the best tools in the world. If a patient doesn't use them, it's not going to help us at all. Avoiding cold temperatures. Why are we going to avoid cold temperatures if they have poor blood flow? what does cold temperatures do to our blood flow? Yeah, it slows it down, right? We get vasoconstriction. Now, if we're out in that cold long enough, we'll eventually get vasodilation, right? What's that response called? You remember that response from modalities? The hunting response, depending upon where you see it, where it goes to that vasoconstriction and then it puffs up and pumps the blood. Yeah, right? That's what you see with patients or people. I don't know if you've ever seen any of the articles about people that like get trapped out on the sides of mountains. I was just watching one about this mysterious group that got trapped on the side of the Caucasus Mountains. They were out hiking. And when the rescuers found them, they were all like a mile and a half away from their camp and they were naked. Raynaud's is another, right? Well, it's basically what Raynaud's triggers, right? You're exactly right, though, Jaira. Jaira is talking about Raynaud's. That's the constriction portion of it. But then if it super vasodilates, that's trying to relieve even Raynaud's. And that's where Raynaud's gets painful. But like I said, there was this group of hikers that were out hiking in the Caucasus. They got trapped in a snowstorm. When rescue found them, they're all three or, a good distance away from the camp, but they're all naked. And that just seems silly, right? Why would you be naked in the middle of the cold? Well, what happened was their bodies had vasoconstricted so much, the body said, well, if I don't vasodilate everywhere, I'm going to die. So it pumped blood to everywhere rapidly and their body temperature decreased. They started feeling warm. And so they started stripping and they died. Hypothermia. I said exercise as frequently as possible. With arterial wounds, we are going to use no compression. Why are we not going to use compression with arterial wounds? Why do we not want to put, we need the blood flow, right? And compression is going to restrict it. So if you've got a patient with arterial problems, we typically aren't going to put them in compressive garments. Now, Erica asked earlier about venous insufficiency. Venous insufficiency, we are going to put in compressive garments, right? But if it's an arterial wound or arterial problems, not putting them in compressive, right? We want to have them in normal fitting socks, proper fitting footwear, right? We don't want them to wear their boots with them laced so tight that the top of their legs turning purple, right? It's all got to be proper fitting. So what else might we treat them with? Well, medication, right? We might treat them with medication. Well, we won't, but docs are going to treat them with medication to treat their hyperlipidemia or hyperlipidemia. They may do a sympathetic block to block the pain signals. There may be surgery. They may have to go in and do revascularization where they go around clotted areas in the leg, right? They may steal a blood vessel from another part of the body that maybe is less important and create a shunt or a bypass around a really blocked area. May have to do some debridement. Balloon angioplasty. Does anyone know what balloon angioplasty is? I'm sure some of your family members or dads or moms might have gotten this before. Someone in here at least, I'm sure. Yeah, so balloon angioplasty is where they typically cut into a femoral artery because it's the largest artery to cut into, and they run a little wire through the arteries. Now that wire at the end has this little itsy bitsy balloon. And they're gonna go to where maybe you have an area of localized blockage. So let me do a drawing here because I'm really awesome at drawings. So here's my artery, right? And because I like McDonald's too much, I've got all this kind of plaque buildup. So now when I had that full blood flow before, Golden Arches, literally. When I had that blood flow before, I had this whole thing, but now I've only got this little area here for blood to flow through. And honestly, and I think Dr. Sokal talked to you guys about this. If not, it's kind of impressive.
like up to 80% blood flow blockage, we operate normally. It's not until we get to downward 20% or lower do we start noticing it. So by that time, we've already got a big problem. Yeah, 80%, yes, right? So now we're at this and it's starting to block me off. What is this condition called here that I'm describing? Is this arterial or atherosclerosis? Okay, good. It's athero, right? Arterial is just the arteries are going to get hard. So if I have atherosclerosis, I already have arteriosclerosis. That means the arteries aren't moving as much. So the plaque's building up. Plaque is athero. So what the docs are going to come in and say is, okay, so I've got this blockage here. I'm going to run this little tube up here with a balloon at the end of it. Now, once I get to this portion, I'm going to inflate that balloon. What's that inflation going to do to all that plaque? Wow, my camera that blurry? Weird. Yeah, so it's going to take all that McDonald's arches, right? All those McDonald's arches there, and it's going to squish them all against this wall here. So now that it's squished against the wall because of that balloon, right? Because the balloon blew up and it pushed that all against the wall. Now I've got a lot more blood flow. Just that alone may actually relieve a lot of blood flow issues. So they can do it to the leg too. They can go down and go, okay, well, maybe it's the posterior tibial that's blocked. They can run a shunt down to that, expand the balloon, right? And open it up. They do this in the heart a lot for patients, angioplasties, right? Now, along with this balloon, behind the balloon, they may have this thing that looks a lot like fencing. That's behind the balloon. Does anyone know what that's called? So it's on the back side of the balloon. It's called a stent. So now the surgeon will come in, they'll deflate this balloon. They'll move this line up just a little bit further. So now we're going to move this line up and keep pushing it up in. And now the stent is here. Now they'll put the balloon inside the stent and blow that balloon up again. And the stent has little hooks in it. And when that stent blows up and pushes out, it basically is like if you've ever driven on alongside a cliffside that says, watch for falling rock or something like that, and you see those fencing that they have, that's essentially a stent. So they'll push that stent out, it'll attach to the arterial walls, and it'll squish and keep that fatty group back. Right? Now, the downside to this is there's two problems. That stent can move, and it can actually migrate. Not a good idea. Some of these hooks can break off and migrate. Not a good idea. But when you think about it, if it's going to keep you from dying, I think I'm happy to get a stent put in me. Just saying. That's my personal opinion. But the other thing is now that you've got that in there, you've got another area where stuff can build up on. So eventually, if you don't change the modifiable risk factors, it's just going to fill back up again. Right? So even if a patient has this where they do balloon angioplasty, if they don't change their habits, it's just going to fill right back up. And then, of course, they can do amputation if need be. Right? For us, we're going to treat it like everything else. We're going to treat it with wounds. So here's some common arterial wounds. You can see them very clear. Definitely that toe is an arterial wound because it's gone, right? That's got a little bit of gas gangrene too on it now. Pretty pictures. So these are typically where you're going to see arterial wounds. Again, typically going to see them on the anterior lateral side of the leg. That toe is sad, isn't it?
Yeah, that toe's gone. There's nothing they can do to save that. And they can't save the second toe either. I'm going to guess they're probably, if I was to hazard a guess, they're probably going to take that forefoot. Because I'm guessing there's probably some infection back here too. I mean, just looking at that toe there kind of tells me they probably have some infection back there too. But I'm not a surgeon, so I don't diagnose. But you can see in all the wounds, the wound edges are pretty evenly designed. This one looks like it. The one on the bottom here looks like a teardrop. Isn't that cute? Oh, it's a teardrop. No, it's not cute. Those wounds are not fun. The wounds will hurt. So now we're going to talk about venous wounds, right? And this is not wounds that happen from the planet or when the Venus is in transit or retrograde or whatever else Venus goes into. So this is poor circulation back to the heart, not from the heart. It can be caused by venous sustained hypertension, meaning there's too much pressure in the veins themselves. Well, why is that? Well, the veins have a one-way valve, right? So if we're looking at this bottom picture here, I'm going to stick with, I can't use blue because it matches. So blood will get into this section of the vein. We will move our muscles. Moving our muscles will force that blood up into this section of the vein. This valve closes after we've moved that blood. That keeps this portion of the blood up in this part of the vein. And then there's going to be a valve right here. We're going to move again. That blood's going to keep moving. So those valves are there to prevent backflow. When the valves are damaged or they don't close completely, as it pushes blood that way, blood seeps back down. And you end up with what's called venous pooling. And a lot of times venous pooling will look a little bit more purplish, right? Because arterial blood has oxygen. It's going to be dark red or purple skin over the area. And it's usually the first sign of developing a venous ulcer. Skin in the area might become thick, dry, and itchy. With arterial wounds, the tissue is just going to necrose and die. With venous wounds, first of all, it becomes really thick and kind of itchy, dry skin, right? Can be from trauma. I could take I could be playing football theoretically, or hockey, or anything that's contact soccer. I actually saw one back with the, what was our Harrisburg soccer team? I can't think of what the name of it was. Not the Stampede, that was a football team. Anyway, there was a semi-pro soccer team in the capital city of Pennsylvania that one guy had done he was kicking, the other guy kicked him in the shin. And it caused two of his veins to collapse. He had traumatic damage to his veins. He ended up losing his foot because of it, right? Because the blood wasn't getting out of the foot. DVTs can cause it, deep vein thrombosis. What is the difference again between a thrombus and an emboli? Because they're both clots. One travels. Good. Which one's the traveling one? Yes, I usually remember that I like to travel. So embolis travel. A thrombus sits in a bus and it just sits there. That's the way I always remembered it. Previous venous insufficiency injury, advanced age. As we get older, those valves become less and less patent and things block up. You could end up with this condition up here that somebody mentioned before, where we get very close veins, as patients love to call them, or varicose veins, where the vein itself becomes deformed and pushed up to the surface of the skin. That can predispose you to venous wounds. Doesn't mean if somebody in here starts freaking out, like, Erica's freaking out right now because she has one varicose vein somewhere in her leg that, oh my God, I'm going to get venous wounds. Don't totally freak out about that. One varicose vein or even a couple of varicose veins doesn't mean it. Because I know you at this point. I've had you for 5 semesters. But it definitely puts you at risk for venous wounds, right? But again, you modify your standard risk factors, you keep yourself active, you can help prevent this. A lot of venous wounds are going to be from being a stationary person. And you're definitely not stationary. You bounce around enough. There's somebody outside talking. So back to this 5PT method again. So for venous wounds, the pain is a dull ache or heaviness. How does that differ from an arterial wound? What was arterial? Arterial was like electricity because it hurts, right? With venous, it's just kind of achy and heavy. Position for venous wounds, medial aspect of the lower leg, including the malleolus, and just like arterial wounds, it's rarely above the knee. And again, the main reason why it's rarely above that knee is because above the knee, the blood vessels are huge. It takes a lot to block off those blood vessels. Doesn't mean it doesn't happen, but it takes a lot. So if you're given a question on your boards that says the wound is on the medial aspect of the leg, you should probably be guessing venous. If it says lateral aspect or top of foot, you should be thinking arterial. What do venous wounds look like? They're usually really, really superficial. So it looks like just the epidermis has been literally lifted off the skin. It's usually irregular in shape. You saw how the arterial wounds were kind of normal, not normal shaped wounds, because no wound is normal shape, but they had a very defined shape to them. Venous wounds don't look like that. Arterial wounds don't have drainage. Venous wounds have drainage, right? There may be a little bit of blood drainage or pus drainage, but a lot of times it's lymph drainage because the lymph vessels are now exposed. Usually beefy red tissue or a ruddy appearance. The peri-wound area, the area around, often has dermatitis or cellulitis. What does that look like? What does dermatitis or cellulitis look like? Any of you ever get dermatitis before? Okay, puffy and red can be right. That's for cellulitis, definitely. I'm sure some of you have gotten dermatitis of the scalp before. Flaky, there we go, right? Flaky, itchy, scratchy scalp, right? Rashy looking, yeah. There's typically localized edema and swelling. There may be some localized erythema, but remember with arterial wounds, there's no redness. The bloods are cut off. And sometimes I hear skin say, I don't know, I've got this really off-color blotch on my leg. That's when we start thinking venous wound. Pulses, normal and present. Arteries not the problem. It's veins that are the problem. And typically with venous wounds, there's going to be mild hyperthermia, meaning it's going to be a little bit warmer than normal. So how do we assess them? Looking at is the best method with venous wounds. Doppler ultrasound may be useful to find the cause of the ulcer to see where the veins actually collapsed. But for the most part, we just know that once the veins kind of collapse, we're in trouble. We'll assess vital signs, determine if there's any difference proximal to distal. Take a clear and concise patient medical history. That means the patient needs to be honest with us about eating bad foods. And then we'll do the ABI. So how do we treat it in PT with venous wounds? The gold standard is compression therapy, right? Now, if the patient has an ABI of less than 0.8, ABI is, or the compression therapy is contraindicated. As long as they're in the normal range, it's not contraindicated. The goal of compression is to reduce the localized edema and localized congestion. Again, the pumping mechanism has failed. If we can use some compression to help that pumping mechanism, it will heal. Usually we're going to do graded compression up to 40 millimeters of mercury. All of these, the Uniboot, the Pro4, and the 2M or 3M, two-layer system. All of those, I have videos there on how to do, how they're performed, but all of them are designed pretty much similar. You're going to put one layer on that's going to be a protective layer over the skin. And then you're going to put a compressive layer over that. So you're going to put like a sock over the skin. And then you're going to add compression. Now, when I'm adding compression with a venous wound, do you think I want to go proximal to distal or distal to proximal? Okay, distal to proximal, Renee, excellent, right?
Well, why is that? I want to move the stuff back to the heart. If I start at the top, I'm going to push the stuff down. I want to start at the end and push all that swelling up. So I'm going to keep wrapping around. 40 millimeters of mercury is not a lot, right? That's about half of normal diastolic pressure. We're going to do localized wound care, drainage management. They may get some fasciotomies to drain out the localized swelling where they cut open the skin. We're going to protect anything that's healthy, enhance venous return, get them up and moving. That's weird. I didn't know I added that picture afterwards. I lost my page. There we go. Wow. I just like that picture. Teaching patients to put, it may, absolutely, Renee. Massaging distal to proximal will be helpful. And a lot of times they're going to be seen by decongestive therapists that help do that. Absolutely would, right? We may want to do some massage distal to proximal before we put on the pressure garments to help keep some of that swelling out. Why do patients not wear their compression garments? Because patients don't like to wear them. Yeah, they're hard to get on and take off. They're 100%. Even for us that are healthy, because like when I fly, I wear compression socks on my legs because it helps me keep from cramping while I'm flying. They're just a pain in the butt to put on and take off. Sock aids can be amazingly useful. Now you got to think about it. You've got little grandma who's got arthritic hands, and you're asking her to put these stockings on that, you know, Kaylee struggles to put on her patients in the hospital. Patients don't like that, right? A lot of times they'll be ordered, you know, hip high compression stockings, and they'll be down around the knee because the patient can't get it up over their thighs. I have yet to ever come across a patient that the stockings go on this easily. This is 100% a model. There's no way. Like, we want you to model these and make them look good. They're not very comfortable. We're also going to do a lot of therapeutic exercises. Limb elevation, right? We know what's swelling. If we elevate the limb above the heart, the swelling will help return to the heart. Pain management, we may have to give some oral antibiotics if they have cellulitis, because cellulitis is an infection. If there's no response to treatment after 3 months, surgery is going to be needed. They're going to have to debride the necrotic tissue. They have to do some skin grafts, right? Oops, got a skin graft. And some surgery to reduce that venous reflux. They may have to do some shunting, or they may just block off some veins. So if we don't respond, if we don't get them, and I tell patients this when I was doing wound care, is you've got a venous ulcer. If we don't take care of it in 3 months, you're going to have to go in for surgery. That's usually a good enough threat for most patients. They're like, okay, tell me what I got to do. Because the last thing patients want to do is surgery. Well, some of them actually like surgery. They're weird. Here's some beautiful venous wounds. Now, do these look a lot different than the arterial wounds? Yeah, right? You can see how they're kind of very irregular, and it looks shallow, right? That one in the middle, I don't know what to describe it. Looks like Walking Dead bite marks. Yeah, it actually does. And there was a PT that did a whole, I forget where I was reading it at. I want to say it was the APTA had an article about it. But this whole PT did a write-up that the Walking Dead, the zombies in the Walking Dead are a combination of rabies and cellulitis. Right? Yeah. We have nothing better to do than come up with a theory of what the virus was that caused Walking Dead, right? Let's just analyze that. They do kind of look like burns. You're 100%, right? The major issue with the difference here is that, you know, there's not a burn cause for it, right, Emily? With the burn, you kind of know, if you had that burn on those lower legs, you know what you did to cause that. This, they just kind of open up, and that's the way they look. And I've had a patient that's gone from completely, you know, healthy, normal looking leg to this in a day or two, where the skin just kind of flakes off, breaks off, and leaves them with this nasty shallow crater. Right? So what do you think wound care wise we're going to want to do to these wounds? Obviously, moisture, warmth, cover, right? Are we going to need to clean them? Yeah, right. We need to get any gunk out of them, right? Get any slough or eschar that's in them. We usually don't have too much. In this middle wound here, the PT may have to come in and remove these skin tags. Right? The areas where skin's still intact, they may actually have to cut those off in order to allow normal kind of healthy granulation to happen. Venous wounds look beautiful. So we've done pressure injuries. We've done arterial. Now we've done venous. The next thing we're going to do, oh, actually, I forgot about this slide. This is a really good slide. If any of you are going out to a clinic where you're going to do pressure injuries, I put two slides in here. I have this slide, and then I have one coming up that adds diabetic wounds as well. Really good slides to keep if you're going out to a clinic that you do wound care on. But these kind of break it down the difference. But that 5P and that 1T is an important. So now we're going to talk about diabetic wounds. They're also known as neuropathic ulcers. What do you think the #1 cause of diabetic wounds is? Well, go figure. It's diabetes, right? Diabetes. So just some interesting facts here. 34.2 million Americans have diabetes out of 328 million Americans. And as they say in a lot of the doomsday videos, and the rate is excelling, right? The rate's getting worse. So we're at about a 10% population ratio. Now, I think they said, I think I was looking as like 20 years ago, we were at about a 7% ratio. Now, two things there. One, we could say that we've gotten worse as a society with diabetes, which we absolutely have. We have gotten worse with diabetes, right? No question. The other thing is we're diagnosing diabetes a lot faster nowadays. So it is a twofold issue here. It's not just that we suck as a country and we're, you know, getting more diabetic, which we are, right? But the other thing there is we are diagnosing it more, especially stuff like juvenile diabetes and stuff like that. We're diagnosing that a lot faster. Out of those 34.2 million, about 15 to 25% of them have had an ulcer. The longer the patient has diabetes, the greater the chance of ulceration. Diabetes is also the leading risk factor for coronary artery disease, strokes, peripheral vascular disease. And here's the thing, hyperglycemia or high blood sugar impairs all three phases of healing. That should even matter to you guys as normal individuals. Let's say you end up, you accidentally, fell and you got this nasty cut on your arm. If you eat too much sugar afterwards, that can impair that wound's ability to heal, right? Everything in moderation. Diabetes often leads to neuropathy and lack of sensation, which reduces the ability to feel pain, especially in the feet. What is the type of neuropathy called that diabetics typically get? Do you remember that? Where they can't feel their hands and feet. Peripheral, good. What's the other term for the diabetes that they can't feel their hands and their feet? It's about the stuff that you put over your hands and your feet. Stocking and glove neuropathy, they'll call it. where the patient's lost the ability to feel in their hands and their feet. It is peripheral, but oftentimes diabetics will get that stocking glove neuropathy where they lose their feeling in their hands and their feet. Well, why? What do you think causes them to get peripheral neuropathy? Anyone have any ideas? What's the structural shape of sugar? Could be, yeah. What's the structural shape of sugar? If you're looking at sugar under a microscope. It's a crystalline matrix. It's not a scientist. Darn it, I'm a PTA student. It's not a scientist, right? It's a crystalline matrix, kind of square. So now I've got too much blood sugar in my blood. And that sugar travels out to my extremities where I have capillaries. What could that sugar do to those capillaries? Block them up. Right now, the nutrients aren't exchanging as much. So now the nerves kind of die off. Now you've got that stocking glove neuropathy, right? Because the nerves have too much sugar in them, stuff like that as well. Poor circulation, obviously a problem here. Foot deformities. If you have a foot deformity, you're likely to get a diabetic ulcer because you already have a predisposition for it. Pressure or friction irritation can cause it. Trauma. And then if you have other vascular diseases, that can also cause and lead you to getting more frequent diabetic ulcers. And then poor vision, right? I'm going to add another factor in here for some people, and I'm going to call that factor the kid factor. Not that kids are evil and are trying to cause you diabetic ulcers, because they're not. But kids and grandkids, if you have them in the house, that also leads to what else laying all around, not directly, exactly. What else does that lead to laying all around your house? Legos, candy, toys, everything, right? Somewhere around your house. And now let's think about it. Now I've got poor vision because diabetes affects my vision. I've got some neuropathy and I step on Legos. Am I likely to know that that Lego just cut my foot? No, right? I had one patient I'll never forget when I was back in Pennsylvania who we were teaching to get used to doing regular daily checks of his feet. So Bob would come in. His name's not Bob. I use Bob a lot, Bob and Millie. But Bob would come in and be like, okay, Bob, did you check your feet today? Yep, checked them this morning. Okay, show me how you check them. And so Bob undoes his shoes, takes his socks down, breaks out his little mirror he keeps in his little fanny pouch. And he's like, huh. And I'm like, what? He's like, my foot says L-E-G-O. His grandchild had put Legos in his shoe. And Bob had walked all the way to therapy with Legos in his shoe. He had one of the 8 bricks, the 4x4, or the 2x4, in the bottom of his shoe. And he'd been walking on it. And guess what his foot looked like? Nasty red. Renee says, there's a story of a dog who saved a diabetic guy's foot from being amputated because the dog sniffed it. Yep. Absolutely. Yeah, dogs are amazing. Oh, actually, animals in general. I mean, there's the whole story of... I don't remember if it was Siegfried or Royd where the tiger detected the blood clot. I wouldn't go that far, but cats are just more likely to kill you, right? Cats are on the long-term game. Yeah, if you ever, so both the dog story is pretty cool and the tiger story is pretty, if you ever get to watch a story on that, there's theory that when he got mauled by the tiger wasn't actually trying to maul him. The tiger knew that he had a blood clot and was trying to relieve the pressure in his brain. And if you look at the way he was bit, it's quite possible. But that's totally a different story entirely. But yeah, it's all part of, if you ever get a chance to watch that story, it's actually kind of interesting, or look up on YouTube. But yeah, so Bob walked to the clinic with a Lego in his foot. His foot was all nasty and red and angry and had almost cuts on it. And so we had to go, Bob, Now you checked your feet. What else did you not check today? Oh, I didn't check my shoes. Right, you got to check your shoes too, Bob. Right? Because he doesn't have very good sight. So with diabetic wounds, let's go back to this 5PT method. Diabetics, pain. Probably aren't going to have pain in the wounds because they can't feel anything. Typically, they have paresthesia. The position, the location of the wound is going to be on the plantar aspect of the foot, specifically the metatarsal heads. Why is it going to be the metatarsal heads, do you think? Why do you think it's going to be on the met heads? Not the meth heads, the met heads. What do we do on our met heads? Do a lot of walking. Yeah, we bump them too, exactly, right? Sides especially, boink. Oh, that was a wall. For diabetic wounds, they're going to be round, punched out lesions. They're going to look a lot like arterial wounds as far as the shape, except they'll have a calloused ridge usually. No drainage like arterial wounds, and there's little no eschar. So the eschar is kind of a hint between arterial and diabetic. But the other thing is, arterial wounds will be on the top of the foot, typically. Diabetic wounds are typically on the bottom. Peri-wound area, the area around is going to be dried, cracked skin. Typically, the patients will have thickened toenails. Did any of you see this on any of your patients? You might have seen that had diabetes. When you looked at their toenails kind of looked like, I don't know how to describe, like they look like wood is the best way I can describe them. Like yellow, clear wood. So they're just so thick and nasty, right? Thickened toenails are a sign of that diabetic effect. There may be structural deformities, right? They may have hallux valgus. They may have all kinds of problems going on with the foot. There's typically some edema present in the feet, but not much. The pulses with the diabetic wounds, it could be varied. It could be normal, could be decreased, could be increased. So we can't go off that just for the diabetic wounds. And again, with the temperature, it's going to be mild hyperthermic, meaning a little bit warmer, which then that tells us it's not an arterial wound because arterials are cool. So we're going to assess the patient's global functioning, including gait, balance, vision, hearing, strength, and mentation. When I say mentation, what do I mean by mentation? Mentation means, are they cognitively there? So what could I do to test the patient's cognition? Ask them questions, right? Tell me a story. Tell me about your godchildren. Tell me about your grandchildren. Tell me about your kids, right? All of those are really good ways to test their cognition. If they're telling you that, oh yeah, I have an alien, he lives on Mars, maybe not cognitively there, right? Or if he tells you that his grandson is Mickey Mouse, I mean, he could be. Maybe he's Mickey Mouse down at Disneyland, but we're going to assess circulation, check their pulses and capillary refill. Doppler ultrasound's always good. We're going to do the ABIs. More importantly, with diabetic patients, we want to assess their sensory integrity by using Sims-Weinstein filaments, right? It's typically the gold standard. Did any of you guys see these? A monofilament test while you're out on clinicals? Renee says no. Renee, you missed out a lot. No, you had some really big patients out there. Yeah. So Michelle says, yeah, she's seen them, right? These are a 5.07, I think it's nanometer or micrometer, I can't remember, monofilament wire that exerts 10 grams of force. So this is kind of what the wire looks like up here in the upper corner, right? It's just this thin wire. Now, this is another one. These are the disposable ones down here. We have a couple of those at the school. Now, with those, you're not trying to poke it through the patient's skin. I've seen this before. Somebody gets the monofilament out, they get it out, and they're like, ha, I'm going to jam it all the way through their foot. No, that's not the point of the monofilament test. How hard are you supposed to push, Michelle? Did you see how hard they pushed with the monofilament until it did what? Did you see that at all or pay attention to that at all, Michelle?
really until it starts bending. Yeah. So until you start seeing a little bit of flexion on that monofilament, that means you've got the necessary pressure. With diabetics, we want to test in all of these areas here. So we're going to test on big toe, middle toe, baby toe. And then we're going to test in here. What are we testing? What area are we testing there? That's in the bottom of the foot. What part of the foot? Anatomically. Come on, we get through it so we can get a break. Okay. Plantar surface of the foot. What bones are right there? I know this is hard. This is anatomy. The pedal bones. Okay, the metatarsals, good, right? So we're testing one end of the metatarsals. We test back here across those cuneiforms and the cuboids, right? And then we go back here and we test the calcaneus. So that's all on the bottom of the foot. And then we come up to the dorsal part of the foot and we kind of test right there between the toes. Now, if you remember, I talked a little bit about this last semester with nerves. Do you remember what we test or what we're checking for when we squeeze between those toes? What are we looking for there when we squeeze that nerve area that gets sensitive between the toes? See if anyone remembers. If not, I'm going to tell you to go back and look it up. Nobody remembers. That'll be an assignment then. There's a specific condition we check by squeezing those areas between the toes to see if they have problems. We'll make that an assignment. That sounds like fun. So we're going to do localized wound care on the diabetics. We may have to debride them, moisturize them, and use toe spacers. Because patients, we have to teach them to moisturize their foot except between their toes. Patients get a little overzealous. They'll get out their foot lotion or hand lotion or whatever they're using. There we go, an aroma. Good job, Adrian. You saved everyone from having, and so did AJ. Save you guys from having to do homework. Morton's neuroma. Good. Mormon, could be Mormon's neuroma depending upon the person's religion. But it's normally Morton's neuroma. It's close enough. I would have passed you at that one. That's fine. No, not only. But patients will get out their lotion. They'll like goop their hands up with their lotion, and they'll get down on their feet and they start slathering it all over their feet. And they start slathering it and they get that right between their toes. The problem is they don't want to get that lotion between their toes because that'll macerate really quick. And they'll end up with more problems. The most important thing with diabetic wounds is to offload them, meaning take pressure off of it. Diabetic footwear itself is the ugliest looking footwear you'll ever see. It just doesn't look comfortable. It's not fun to wear, but the goal of it is to protect them from getting further diabetic ulcers, right? We're going to typically use a TCC or total contact cast in order to prevent it. This looks like, if any of you have seen I used my Mormon Google. God, you guys are horrible. The total contact cast looks like a normal walking boot that we're going to put them in. And actually, if we don't have a TCC present, a total contact cast present, we can use one of those moon boot walking boots to protect the foot as well, because they have a lot of cushioning in them, right? But the goal idea here is to remove pressure off of that walking surface so they don't get it worse. We're going to get them doing therapeutic exercise. That means we're going to be doing foot therapy, right? We're going to have them doing toe curls, picking up stuff with their feet, right? All that fun stuff. Get them doing some aerobic exercise to increase glycemic control, right? There's a ton of research out there that shows aerobic exercise helps maintain your glycemic control a lot better. Gait, showing them how to walk properly, maybe getting them assisted devices, right? Maybe a walker, maybe some orthotics. Maybe they need some help that they're not getting enough. That's great. That actually makes a joke even funner, Adrian. Thanks. It auto-corrected. Temormans, not Temortins, right? That's what it was. Blame it on autocorrect. Darn you, autocorrect. We may have to design custom orthotics. We may have to put inserts in their shoes to help relieve pressure. They make little donuts to put around the diabetic ulcer that we can put it around it so that when they put their foot in, it distributes the weight around the diabetic ulcer rather than being on the diabetic ulcer. And patient and family education is big here, because one of the things we're going to have to tell them is you need to manage your sugar. If they don't manage their sugar and they keep getting diabetic foot injuries, what is eventually going to happen to their foot? Yeah, it's going to get amputated. Right? I can guarantee, we're having fun here. I can guarantee most of the amputations I have seen have been diabetic patients that just don't manage their sugar. Right? So here's some beautiful diabetic wounds. So the top left one, definitely your typical diabetic presentation. Right? This is your typical diabetic presentation here. Right? And that's usually from pressure relief, probably had improper fitting shoes. Even this one on the right, pretty common presentation right there on those heads. Now this one here, we have a combination of problems. Right? And this person here, what do you see is missing on the middle patient? Yeah, we already got some toes gone. So he probably didn't manage them in the first place, right? What else do you notice about the feet? Other than they nasty. Didn't learn from the first toe. Hasn't learned from his, what are we at, 4 toes now. What else do you see about the feet? Okay, they're flat, good. They're really wide. Yeah, why are they wide though? It's got a lot of edema. Yeah, they're really swollen feet. I mean, just look at this. The other thing I see is, here's his metatarsal. He's got some hallux valgus going on, right? So there's a lot going on. He's also got some cellulitis, right? Some definite caking and drying of the foot there. All of that's going to have to be taken care of. Out of these 3 pictures, I'm guessing this guy here is probably going to lose his feet eventually. I mean, he didn't learn from 4 toes. He's probably going to lose the feet eventually. Just imagine, though, this guy in the upper right corner, right, having diabetic ulcers on both plantar surface, which is totally a girl. The one in the middle? Yeah, it might be. I don't know if it's a guy or girl. I'm equal opportunity offender to tell them they need to take care of their feet. But just imagine that person up there with both plantar surfaces with a hole in it. Right? What do you think that's going to do to them? Do you think they're going to walk a lot? If both your plantar surface, yeah, no, right? So now what's that probably going to lead to? More problems. So we're probably going to cast that guy as soon as possible, right? Sitting, yeah, we're going to end up with pressure ulcers, pressure injuries then. Got to get us calling pressure ulcers, the pressure injuries. All right, so I think the next section, so there's that next slide that I talked about again, the difference between arterial and diabetic. Again, good for you to put in your folder for when you're out in the clinic. That's why I created these. Also good to help you study for your boards. Let's take a quick break here and then we'll come back and we'll finish out this lecture. So I'm gonna stop sharing here. Let's take about 5-10 minutes, take a break, come back, we'll get into burns and we'll get out a little bit early today, hopefully. So go grab some caffeine, I need some more coffee, and we'll get started back here in a few minutes. All right, so we're gonna resume recording here. We're gonna talk about a burning topic. No? No? Oh, no one? I know, I should quit my day job. Thanks, Michelle. We're gonna talk about burns, because some of you may encounter this. maybe even get to work with burns, which honestly, working with burns really makes you appreciate what you have. To be 100% honest, whenever I've worked with somebody with burns, it's just really, it's kind of sobering. There are about 2 million burns every year in the United States. You're the best. Wow. Out of the, I'm just going to keep moving. About 50K of those require hospitalization. 20,000 of those 50K have about major burns involving at least 25% of their total body surface area, and we'll talk about that in a bit. Around 5K die from burns in the US, about 100K die from burns, 180K die from burns worldwide. And then another 10,000 die from burn-related infections, so infections after the burns. This is an interesting topic here as well because this surprised me. Less than 60% of American households have an escape plan. Yeah, those 60% graphs really make you appreciate your life, doesn't it, Justin? So I'm going to ask this because we have several families in here. Do you guys have written escape plans? What happens if your house catches fire? Do you have an escape plan other than running around with your hair on fire? Kelly's like, yep. Jump out the window. Michelle says, yeah. Okay, good. I will be honestly and 100% admitted. I'll have to watch the YouTube video here in a second, Erica. I'm going to be 100% honest about this. Growing up, I didn't have an escape plan in my house. And I grew up in a mobile home, otherwise what we would call trailer. And I don't know if you guys are familiar with trailers from back east. We can? Sure. Let me look at it first. Give me 1 second just to get through the thing. But I don't know how many are familiar with trailers, but trailers are like giant tinder boxes. Once one part of it goes up, the rest of it's going to go up. Usually if they burn to the studs. There's not much left of them. So I didn't have a escape plan. And honestly, we didn't have a fire alarm either in our house. So fire alarms, smoke alarms reduce your risk of dying from a fire by 50% or more. So think about that for a second. Let me pause recording here. I'm just going to pause so I can see what this video is. Yeah, less than 60% of families have, nice brain break, exactly. 60%, less than 6% of households have an escape plan, right? You know, most houses may only have one exit. No problem. What about school? What happens if the fire is in the lobby of our school? We're kind of in trouble, right? Because our doors are that way. We can go through my office. But if my office is on fire, we're really in trouble because we have no other exit. We're stuck in there. And then we'll start stealing snacks. Crawl through the ceiling. Exactly. We learned that, right? Throw the cat up through the ceiling. Interesting thing here, though, is out of the people that have burns, about 1/3 of the burns are children. And I'll say when I had done some burns on my one clinical rotation, that was probably the hardest thing to deal with. Because so if we figure 2 million people are burns, 1/3 of those, you're talking, 600,000 of them are children. And out of those 600,000, about 60 to 70,000 of them are child abuse cases. So they were intentional burns. This is interesting. I don't know why this came up when I was doing my research last night. 175,000 Bangladeshi children suffer moderate to severe burns yearly. I don't know why that was interesting to me, but that just was like, just in that one country, almost 200,000 kids get burned a year. The cost for children's burns exceeds $200 million a year, and they're the fifth most common cause of non-fatal childhood injuries. Most of the burns happen in home, and over 75% of them are preventable. Think about that for a second. 75% of burns are preventable. So we got some great pictures here. So top left corner, yeah, lack of supervision can be. Top left corner is a kid Kaylee's like, I can't do peds. Exactly. I put a lot of the kid pictures in here on purpose. So the ones that I saw that were child abuse in the hospital that I saw burns at were from the waist down. A lot of them, the kids were burnt from here down. Why? Why do you think they're burnt from the waist down? Yeah, bathtub. There's two reasons. Now, number one, it could be that, you know, mom just made a mistake and didn't realize how hot the bath is, right? We had a couple of those where, you know, mom didn't check the bath water before she put kid in, and bath water was not, you know, bath water temperature. It was scalding. There are other reasons that, for some reason that I never understood. We had one where the lady kept dipping her kid in the water because she thought it would stop him from crying. And yeah, that, I don't know. This one up here, does anyone know what this burn's indicative of? The one in the middle? I saw a couple of those. That is not parental burn. That's not child abuse there. Does anyone know what that's from? Nope. That's hot stove. Mom or dad was cooking. Kid got to the stove and pulled the pan. So it could be spaghetti, could be you're making mac and cheese for the kid. That's actually a common burn pattern for kids. They pull on the pot and pot comes right at them. Out of all of those, I saw one that was grease. That was by far worse than this is. I'm sure that's probably hot water. What's this? What type of burn is this one here on the right? Yeah, that's a mechanical burn. That's actually a rope burn. Close. Yep. That's what's called a mechanical burn. That was person had rope wrapped around their hand and it just yanked across, right? I think if I remember correctly, that was a climber. Don't quote me on, I'm pretty sure it was that I pulled this from. You know, rock climber, and they slid down and the rope just literally took the skin with it. And then over here on the far left, does anyone know what kind of burn that is? Not fire. That's an exit wound from electricity. So when electricity goes in your body, the problem is not necessarily where the electricity goes in. You'll get a minor burn there. It's where the electricity comes back out, because it has to exit the body somewhere. And usually you'll have blowholes like that where the electricity exits. That guy's lucky because it's a small blowhole. I've seen them where it blows off the whole hand. Kaylee's like, nope, can't do burns. I added that one only briefly just so I didn't totally freak Kaylee out. So what are the causes? Believe it or not, there is a direct correlation between SES and burn care. What is SES? You hear a lot of it in psychology and sociology. SES is social economic status. So what does that mean? There's a direct correlate. Yeah, good job, Jara, right? I just beat you to it. So direct correlation to low income and burns. Both receiving burns, there's a higher risk at burns for lower and middle social economic status, but also the care they receive is typically lower because they don't have the proper health care. They don't take the people for proper health care. So socioeconomic status affects burns of the middle and lower class than it does the higher class. Occupations increase exposure to fire. Why is that? It's a great question. Why do you think low SES classes are more likely to get burns? Well, there's a couple of you guys in here I know that have worked as cooks or worked in kitchens before.
What type of people typically work as cooks in kitchens? Lower socioeconomic status, right? Unsafe, cheaper home utilities, the other problem, exactly, right? You know, it's great that we can get cheaper lights and stuff like that from Walmart, but are they always as safe as high quality ones? Probably not. Right? I'm kind of picky about my LEDs that I put my bulbs in. I like cheap, I like being cheap, but I also don't want starting a fire in my house. That could be bad. Also, I don't know, you guys, again, I grew up really kind of poor, right? And in the house that I grew up in, we didn't have, so we had a heater, but the heater was expensive. So we heated the house with an oven. And we also had kerosene heaters that we put all over the house, or a trailer, but, right? And oftentimes those kerosene heaters were sitting on carpet, not the smartest choice in the world. Yeah, yeah. I've seen it where people have used, so Emily talked about gas stove exploding. I've seen people that have never used gas before and then suddenly get a gas stove and don't know how it works. Right? Because they think they just turn it on like you turn on an electric stove. So they turn it on and let it on. And some of them don't have the auto strikers. Right? The gas stove I had in one of my places, you turned it, and as soon as you turned it on, the striker, click, 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 and lit it. But some of them you have to press to get the striker to work. So now they're turning it on, the gas is going, but nothing's lighting it. And they're like, oh yeah, I've got to press that striker. And they press the striker, and what happens? Boom. Right? I'm sure some of you have done that on a gas grill before, where maybe you turn the gas on and forget about it, and then you lift the top and you light it, and woof, that fireball goes up. Right? I know, I'm going to openly admit that. Poor wiring in homes. Like Kaylee said about unsafe, cheaper home utilities. They also tend to live in not exactly the best apartments. Right? People that have lower socioeconomic status, so they have less quality, you know, wires and outlets and stuff like that. And where any of you ever, what was the show from the Halloween or from the holidays? The You'll Shoot Your Eye Out movie, The Christmas Story, right? Did you ever see that where he's plugging all those lights into that one outlet? Yeah, that was my family. Like you just plugged, you know, you got an extension cord, and the extension cord had an area that you could plug another extension cord in. That extension cord went there. That extension cord went that way. Christmas Vacation also has it. Yeah, right. So yeah, low socioeconomic status. And then why are they less likely to seek out medical care? Can't afford it. Yeah. No insurance, maybe. Too expensive. Or, you know, maybe it is that they burnt their kid and they know that if they go, and they didn't mean to, but if they take the kid for a checkup because of it, what's going to happen? Yeah, CPS will be called, right? I mean, you got to think about this, especially, you know, okay, let's say you're a healthcare worker and you see a mom that's disheveled and she just doesn't look like she's put together, but she brings in a kid and the kid's got severe burns on his hands. And the mom's like, no, he literally was going down the slide and it was a hot slide. He put his hands down and he got brush burns the whole way down the slide. And she's being honest about it, but we look at her and go, really, mom? Really? Just there's some inherent bias there, right? You weren't taking care of your kid. I'm going to call CPS. People ask questions. Yeah. Poverty, overcrowding, lack of property safety measures leads to fires, right? Go back to occupations and increase exposure to fire. People that work in kitchens. This hand here, my left hand, before it was numb, I ended up accidentally dipping in a grease fryer when I worked in the kitchen. I don't ask how I accidentally did it. I still to this day have no idea how I accomplished it. But I got a burn on the back of that hand from it. What other occupations exposed to fire in this area? Well, firefighters, obviously. What's Nevada known for? Gambling. Okay. Yeah. Then now we'll go with that. Now it's known for gambling, hot weather, dry heat, mining. Yeah. The silver state. Exactly. How do you think they get that silver out of there? By blowing up holes. Well, sometimes they blow up that hole and there's a hydrogen pocket under it. And you get what's called a flash fire in the mine. Right? So all of that comes into play. Improper cooking methods. We've all done this. We've all cooked things the way we're not supposed to cook things. Right? We've all made mistakes as we're learning. Some of us have set kitchen fires before. Underlying medical conditions like epilepsy, peripheral neuropathy, physical cognitive disabilities, stuff like that can lead to burns. Alcohol abuse and smoking. The microwave on fire when I was younger. Yeah, I lit a microwave on fire this weekend, but we won't talk about that. Alcohol abuse and smoking. Smoking, what do you think causes fires with smoking? What's the number one cause of fires with smoking? Falling asleep. Yeah, right? I can't tell you how many times as a kid I took my mom's cigarette out of her hand and put it in the ashtray because she'd sit there on the couch watching TV and fall asleep, cigarettes in her hand. And again, I told you I grew up in a mobile home. And it was just a top, skip, and a jump. Candles are another big thing, right? Candles are so romantic until you forget about them. Right? And maybe you forgot that the candle was lit and suddenly the candle catches the mantle on fire. Easy access to chemicals used for assault, such as in acid violence texts. There's been a rise of that lately, where people are getting acid burns. Kerosene, which is a paraffin and highly flammable, used as a fuel source. It's common. And then just inadequate safety measures for liquid petroleum, gas, and electricity. It's common for people just, let's say you're pumping gas at the gas pump. Yeah, the Zappos guy just died from fire, exactly. You're pumping gas at the gas pump and you overfill your tank. And some of it spills onto the road. No big problem, right? Just leave it. Why could that be a problem? Till someone starts smoking, right? Or they come through with a piece of metal dragging behind their car. Like that never happens in Vegas. Yeah, a little spark set it off and the whole gas station goes up in flames. So we have to be careful with that type of stuff. Electricity. You know, I build computers quite frequently. I've had computers catch fire. There's a big problem right now. And if you don't believe me, go look it up. There's a bunch of YouTube videos on it of a company called NZXT. NZXT makes beautiful parts for computers, but they just designed a new small form factor desktop. But the problem is the screws they use to hold, I want to say it's the graphics card in place. I can't remember which it is, either the graphics card or the power supply, are nylon threaded screws. This is the GPU, okay. And when the GPU heats up, it evidently is melting these screws and catching them on fire, and the whole computer goes up in flames shortly thereafter. Now they've issued recalls on it, and they're sending out the proper parts to fix people's computers that have it. But even something as simple as a screw can lead to things just, well, screwing you. No, I thought that was a fire joke. It was pretty hot. So any of that can come into play. I know my jokes are horrible. You guys miss them. You admit it. So what do burns look like? Well, we have a couple of different types of burns you first have to understand. We have thermal burns. These are our common ones. Direct contact with flame, hot liquids, or steam. What determines the severity is how long they're in contact for, temperature, and the type of insult. Let's say you're cooking over, has anyone ever done this? Because I've done this before, and I'll openly admit it. I'm getting ready to cook spaghetti on the stove, and I've got water boiling. And of course, we know that
If you put the lid on the water, it boils faster because it keeps the heat in, right? And then you lift the lid off the thing and you're right by the pot of boiling water. Now, if you're like me, your glasses fog up, but did anyone ever have that where that steam goes up your nose and you get that nasty burn feeling in your nose? Right? Yeah, right? That's a small contact of it. But what if you were in that for a long period of time? That could really mess up your sinuses, right? It's the most common type of burn is thermal. About 80% of all burn admits are thermal. Chemical, strongs, acids, or bases that react with the skin, right? What kind of stuff could be strong acids or bases in our house? Nail polish remover, okay. Milk, yeah, right. Bleach, all of those can be strong, right? If I throw bleach against your skin, it may not do much, but I throw it in your eyes, big problems, right? Even bleach against the skin is kind of an irritant, right? Lye, not like L-I-E, L-Y-E, big problem, right? All that can be a problem. The interesting thing with chemical burns is the burning will continue. What happens if I have, maybe I spill hydrochloric acid on my arm because I'm working in a factory or something, and you spray water on it? What have you done? It's going to react to the acid, right? The other thing is you've spread it now, right? It's kind of similar to a grease fire, right? What happens if you spray a grease fire with water? The fire kind of goes everywhere, right? So what do you do with chemicals? How do you take care of a chemical burn? Salt could work, okay, good. Hydrochloric acid, you got to be careful. So you got to know if that could be a problem with that, but you don't exactly keep hydrochloric acid in your house. And if you do, I really want to talk to you later. No. Neutralize it, good. What's a common neutralizer you have in your house? The same thing you might put on a grease fire. Still salt, okay, yeah. What else? Lid, okay. But a little baking soda, there we go. Baking soda is a good one, right? Ironically enough, just dirt, sand, anything like that can help with the acid burns and chemical burns. Coffee grounds, excellent use, yeah. Right? If you're in a kitchen, you get a burn like that, coffee grounds will do it. Like even if you have a grease fire, coffee grounds work pretty good for putting that out too, because they're usually a little bit damp, and they kind of put it out. They smoke really good too, and smells good afterwards. And then we have electrical burns. Not typically. I mean, I don't know that there's like oil from a car, or are you talking like oil from food? Which type of oil are you talking? Because oil from a car is a definite no-no. If you're talking like oil, like, you know, castor oil and olive oil and stuff like that, it can clog up your drains really bad. Yeah, French fries, not a good idea to dump that oil down the drain. It's not gonna, things probably aren't gonna catch fire, but you'll probably have a visit from Roto-Rooter eventually because it'll clog up your drain. Electrical, prove a point to my mom. Mr. McKeever said, I got electrical next. Electrical. The important thing about electrical is to understand there's a charred entrance and an explosive exit. That means where I grab things is going to be where it chars, and there's going to be somewhere else where the electricity exits me, and it's going to be exploding. The good news with electrical burns is we're not going to see a lot of them because most of the people die. We had one in Pennsylvania that was literally right outside the hospital. They were doing work on those high tension electric wires, and the guy lost his balance on the ladder, and he grabbed a hold of the wire that they're fixing, which was bare. The electricity burned his hand, but it was such a high velocity and high power electricity, it went out through his neck. So literally his head popped.
And of course, the news was all over it. Man's head explodes because of high tension electric wire. Are they safe in your backyard? I'm not going to be touching them regularly. I'm just saying. Mechanical burns are those friction burns, right? Rug burn, rope burn, road rash, all of that. Kids are common. Kids get these type of burns all the time. They just do, right? From playing around, rolling around on the ground, bikes. It's not common for adults to get a lot of these burns, but sometimes we get them, right? Historically, burns have been classified by degrees, meaning 1st degree, 2nd degree, 3rd degree burn. We don't classify them that way anymore. There are still facilities that classify them. That's not the proper way anymore, but here's the deal. If you go to the facility, and like Renee's correcting her mom right now, you don't go to the facility and say, well, Mr. McKeever said we don't do 1st degree burns anymore. No, don't do that. But a lot of insurance carriers will start rejecting them as they keep coming back 1st degree, 2nd degree, 3rd degree burns, right? The burns are qualified by the area of tissue, just like wounds. Superficial thickness. What do you think is affected in superficial thickness burns? In a superficial thickness, what part of the skin is probably affected? Yeah, the top, the epi, right? Then we get a superficial partial thickness burn. So what do you think the difference between a superficial partial thickness and a deep partial thickness is? Yeah, epi versus dermis, right? Usually superficial partial thickness is the epi is gone and we're down to the dermis. Now, some of the books will say some of the dermis is affected as well, right? Whereas we get to that deep partial thickness, we're definitely down into that dermis, right? And then full thickness, how much skin's left? If you have a full thickness, nada, it's gone, right? And then subdermal, now we're down into that subcutaneous tissue and the bones and stuff like that. So this is the rule of nines, right? This is not the rule of mines. That's fine, thank you. The rule of mines is what the seagulls in Finding Nemo have. The rule of mines, mine. The rule of nines is the measurement for burns, right? You are expected to know this for your boards and not like get this chart and be able to translate it. You have to know this. You have to know that the front part of the arm is 4.5%. The back part of the arm is 4.5%. The total arm is 9%. Hence the rule of nines, right? So let's go over this real quick. My head, total head, how much do you think it's worth? 9%, good. My chest, just the front portion, how much do you think it's worth? 9%, good. The back, top portion, 9%. You see how this works, right? The arms are where it gets a little hinky because the full arm is 9%. The anterior aspect is 4.5. The posterior aspect is 4.5. The arms where it changes. The legs, the front half is 9%. The back half is 9%. The one that everyone remembers and no one ever forgets about is the perineal region. For some reason, everyone remembers that's 1% of my body. I don't know why. I can ask 50 questions on this stuff, and for some reason, that's the one everyone remembers. Like, seriously. We are, especially the guys. Guys, remember, I think I'm worth more than 1%. No, that's 1% of your body. I don't know who did this drawing, but for some reason, the Illuminati eye is creeping me out here. Now you can't unsee it, can you, Erica? It looks like a guy that's surprised. Here's his eyes. Anyway, y'all seeing eye, the belly button. So
it is unlikely, because this is where we're going to end for the day. We'll pick the rest up tomorrow. It is unlikely that your boards would say something like, your patient has a burn to the anterior surface of the neck and the anterior surface of the chest. What is the percentage? It's unlikely. Doesn't mean it won't happen. I can't promise that, but it's unlikely. But it is common for the boards to say, your patient suffered full thickness burns to both arms, anterior and posterior portions. What are the total percentage of body covered there? Well, you go, oh, 4.5, 4.5, 9, 4.5, 4.5, 9, 18%. You got it, Renee. You're right there, right? Or for some reason, again, the boards are just like that. They'll say that the patient suffered a full arm burn along with inguinal region. So now you got 9% plus 1%. So you got 10%. Right? I don't know why even the board's questions tend to go after that. It's just hilarious to me. So what if the board said the patient suffered superficial thickness burns over their whole body? What percentage of total body surface area is covered? Well, if it says the whole body, 100%. Yeah, don't let something like that trick you. Because what they'll do is they'll have this whole long paragraph talking about how the burn happened. Patient was rushed into the hospital, had debridement, blah, 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 and suffered partial thickness burns over all over the whole body. What percentage of the body is burned? And you're going, oh my God, there's so much in this question. Like, oh, wait, it says whole body, 100%. Does that make sense? So don't get totally tripped up. The one, I have both these on here. This is the one I memorized for my boards. That pink one over there. And that got me through all my board questions. Okay, so don't totally freak out about this. Just remember that the arms, total arms are worth 9%. How much is a total leg worth? 18%, good, right? How much would the whole trunk be worth, excluding the groin? The whole trunk, 36, right? Because we got 9, 9, 9, 9, right? So we got 36%. What do you think a good rule of thumb you would want in order for the person to survive? What percentage or under? Just give me an estimate. You don't have to be exact. Okay. Yeah, some will say 40% or under. 50% is a good rule, right? But is it really about the percentage or the type of burn? Yeah, type, right? So let's think about that. If I have 100% superficial versus 40% full thickness, the 40% full thickness is more likely to die. Does that make sense? Because some of you may have gotten close to 100% burn before if you laid out and fell asleep. Right? You didn't die from the sunburn. It sucked for a couple of days. Right? But now I come along and I pour acid on you and eat away at 40% of your body, you're going to probably wish you died because it hurts. So please make sure you study that. I can guarantee there are at least 3 questions on your final about burns. Either TBSA, total body surface area, or types, meaning, you know, is it a full thickness, partial thickness? So again, going back here, just to review this before we end for the day. Superficial thickness, epi. Superficial partial thickness, epi pretty much gone, getting to the dermis. Deep partial thickness, we're into the dermis, right? Epi's gone. Full thickness, we're down through, we got no skin left. And then subdermal, we're down into the tissue below. It could be all the way down to the bone, theoretically. That goes pretty closely along with pressure injuries, doesn't it? And also types of wounds. This is why we're going to these standards, so that they kind of match up. So is everybody burnt out? All right, so let me close out my share here. We'll finish the rest of this tomorrow. Go get yourself some lunch and some food. And I'm going to figure out why my camera looks so horrible. I think it's focusing on Snecky behind me and not focusing on me. Did you guys see? Snecky's got a mask on now.